Thank you. Okay. All right. Good morning, all. Over the weekend, you had 2 chapters, chapters 5 and 6, to read and take the test in the white book. When I call your name, if you can tell me how many you missed or what your score is. Kayla? Felicity? For both? Thank you. Jamie?
95 and 90.
Thank you. Peyton?
I just got a 95 on one, and I'm
Okay.
doing the other.
That's fine. Gloria? For both?
Oh, I only did the first one.
Okay. That's fine. Kenley?
90 and 100.
Do you have 4 for me, Kenley?
I do. It is 100.
Thank you. Good morning. Melissa?
95 and 100.
Thank you. Tasha?
95 and 100.
Thank you. Nancy? Oh, for both?
Yeah.
For both? Okay, thank you. Jasmine? Jose? Alani?
195.
Thank you. Amelia? Isabella?
I got a 95 and then 100.
Do you have 4 for me? Sorry, somehow I missed that one. 100, thank you. Good morning. All right, any questions on any of them that you missed? Anything that you don't know why the right answer was the right answer and you need me to explain it? Let's talk real briefly about the difference between dementia and Alzheimer's. This kind of messes people up. Dementia is a very broad view. It doesn't mean anything. It just means brain is sick. That's it. That's all dementia means. It's like me coming in here and saying, I don't feel well. Well, you know, I'm not well, but you don't know what exactly is wrong. I mean, do I have a headache? Am I sick to my stomach? Am I achy? You know, I mean, we need more specifics, right? Well, dementia is like saying the brain isn't well. It's very broad. It means something's broken, but nothing specific. Morning. Alzheimer's is a type of dementia. So if I say that somebody has Alzheimer's, that means their brain is sick, and this is the exact sickness that it is. Does that make sense? Okay, so dementia, very broad, doesn't really mean anything other than there's something wrong up here. Things aren't connecting. Alzheimer's is a very specific type of dementia, and it's not the only kind of dementia. There's lots of other things that can cause the brain to be sick. There's Parkinson's dementia, there's Lewy body, there's Huntington's chorea, there's Jacob's Crutchfield disease, there's multi-infarct. Cancer in the brain is going to actually do something a little bit different that we don't normally call that dementia. Okay. But dementia is just a very broad term. It could apply to that, but usually when it's coming from a secondary source like that, we call it a metastasis or something like that.
But not all people with Parkinson's disease get dementia, correct?
No, it's a late stage of Parkinson's.
Because that was the answer that I chose. And then I got confused because I kind of did like the process of elimination because 1 was trauma or fall, and then D was a series of strokes causing brain injury. So I'm thinking, okay, a brain injury could be from trauma or a fall. So that's why I picked Parkinson's.
Yeah, so late stage Parkinson's can result in dementia, absolutely. Many strokes, what we call CVAs or multi-infarct dementia, because it's interrupting blood flow to that part of the brain. So that part of the brain just doesn't work very well anymore. Okay. But trauma and falls, that would be something different. That would be a subdural hematoma or some sort of a swelling issue, hydrocephaly, those type. That's not really dementia. Okay. Yes.
I got 20 wrong on the catastrophic reaction because I put it, wait, no, I meant the agitated one, 17. I put C when they overreact, and the answer was, oh, a resident who's excited, restless, or troubled. I didn't know agitated could be excited.
Yeah. So agitated is low level. Yeah, agitated is kind of low level. Like something is not right. You know, I'm just kind of irritated. Think of agitated like irritated with action. Okay. Have you ever been irritated? Yeah. And then sometimes when you're why is this locked? Sometimes when you're irritated, you take action. You pace, you get on the phone, you start to clean, you there's action involved. Yeah, there are some. Anybody here a cleaner? Yeah, yeah. Some people are cabinet slammers or door slammers. I'm a thrower. Yeah, you get me mad, I'm going to start throwing stuff. I mean, it just, that's how my agitation manifests. We all have, you can't go through life with absolutely no source of irritation. It just, even the richest of the rich, right, that have no problems, still have problems, right? Everybody has days where they're irritated. It's could be environmental. It could be just your state of mind. It could be your blood sugar levels. I mean, there's a lot of things that can cause you to be irritated, right? Sometimes your clothes just don't fit quite right, and the tag's bothering you. Everybody gets irritated now and then. Irritation with action is agitation. It's kind of what we do with that irritation. Okay, fidgeting, throwing stuff, those types of things. Does that help?
Yes, thank you.
Does that help? Okay. Any others? You're not going to have questions like that on the state exam. It's not going to ask you what is the difference between agitation and confusion. It's not really your role as a CNA. Now, if you get into nursing, yes, you do need to know the difference because we're documenting now, and documentation is a legal form. And if I put on documentation that somebody is agitated, I have made a diagnosis. So I've got to describe that agitation. This patient is pacing, wandering, picking at their skin. What makes you think they're agitated? Okay. So documentation from a nursing perspective is a lot more legal. And that's why CNAs generally don't get to document in words. CNAs are usually limited to documenting in numbers, number of pulse, number of respiration rate, percentage of food, how much urine you measured. So CNAs usually are restricted to numbers. Some places, though, do have CNAs documenting in words. If you're doing that, if that is a condition of your employment, if you are actually writing in a patient's chart or typing on a computer, because almost everything is computerized now, make sure you know their policy and procedure, what words you're allowed to use, what words you're not allowed to use, because you will be legally liable for every word you put down. Good. So I'll give you an example of this. There was I'm not sure if she was a home health aide or a CNA. I'm not sure what her role was, but she worked for hospice and she worked overnight at the bedside with a particularly agitated patient that was in the process of dying. And you have to document every 15 minutes what the patient's condition is, what's happening with them. And apparently she was bored. It was the middle of the night, nothing to do. She couldn't have TV on because they were agitated. So she's just sitting there in a quiet room, lights are dim, and she's bored. I get it. I understand. But she started pre-documenting. You know, at 2:30, patient is resting quietly because that's how they had been, 2:45, patient slightly agitated, restless, moving about in the bed. 3:00, patient resting quietly, so she started pre-documenting. Well, the patient died at 2. And here I've got this whole page of documentation telling me the patient was fine at 3:30. That's a legal form. I can't destroy that. She can't destroy that. That's like me going into a courthouse and just starting to tear papers up. You can't do that. So I had to submit this documentation to the corporation and say, it's falsified. This is falsified documentation. And she lost her job over it. Now, I felt bad for her because I understood she was bored. She was tired. Write a story. Don't write documentation ahead of time, because what you put on that paper, you are stating legally, hand on the Bible, one in the air, this was done. So be careful. And for these reasons, generally speaking, you have to be a nurse to document in words. Does that make sense? Yeah, there were a lot of other problems with that situation, but that was one of them. All right. Any other questions on homework? You guys know this? Crazy. We are now starting week 3. So class is more than half over. If you've not registered for the state exam, that needs to be high on your priority list. Don't wait, because when you wait, we got the holidays coming up. Thanksgiving is in 3.5 weeks. And then Christmas is going to come right after that. You've got Black Friday shopping in there. You've got Christmas parties to go to. You got a lot of stuff coming up. And if you haven't registered for the test, all of that stuff is going to distract you. And you're not going to have the money because you got to buy Christmas presents. You're not going to have the time. And before you know it, New Year has come around. And now you're like, oh, I've really got to register for my test. But now it's been 2 months. And yeah, you're at risk of not remembering all the little details. So if you haven't registered for the test yet, now would be a really, really good time.
I do have a question regarding homework, kind of. So the topics that went over, such as cleaning patients and such like that. I'm an idiot when it comes to reading. I prefer visualizing generally. Is there a time you're going to show us, or we're going to see on the mannequin or your video?
Well, we're going to go over partial bed bath today.
Okay, good. Cool.
And we're going over peri-care and catheter care next week.
Wonderful.
Or peri-care on Wednesday, catheter care next week.
I watched the video of yours, and were you taking the patient from laying down to move them into a chair? The way you scoop them up like this to sit them up, is that how we're supposed to do it? I know that's not what you're talking about, but I saw that video.
Right. We haven't got to that skill yet. I'm going to cover that skill in detail.
Okay,
Wednesday
okay.
is when we'll do transfer from bed to wheelchair. But yes, that is how you're supposed to do it.
Okay.
But it's not like this. Everybody thinks it's like a honeymoon carry. That's
Right.
not how you pivot somebody to the side of the bed. This doesn't work, and it will actually cause injury to you because you're pushing with this arm and pulling with this one, and that torques your back. No good. Don't do that. So instead of going like this, you're going to go like this. So one hand under the shoulders, one hand over the knees, and then it's just a simple pivot. And it is super easy, but everybody makes that mistake. Somehow mentally, we're all convinced that you got to do this. And that's how you'll try to do it, and it won't work. If you just flip this arm over, it's like a quarter of the effort. And you'll be like, how does that work? You just moved one arm, but it's a quarter of the effort. But yes, we will go over that in detail on Wednesday. Any others?
When you put somebody in the lateral position, what if they can't put their arm up? What would you do?
Consult.
I'm sure in the test, you gotta do that anyway, but what if a real life patient can't do that?
So if I'm the nurse and I have on the care plan that we're going to change the patient's position every 2 hours, I know what the patient's limitations are. That's part of my job as the nurse. So knowing the patient has that limitation, their arm does not go up because maybe a frozen shoulder or a surgery or whatever, on the care plan, I'm going to have the accommodation for the furthest shoulder. Okay. That's the whole purpose of the care plan. In here, we're kind of learning normal. Okay, this is everything is operating on all 8 cylinders. You're good to go. There's no restrict. Everything is good, right? But that care plan is the instrument that's going to adapt that skill to whatever is going on with your patient. So when you have those what if questions, what if the patient can't scoot? What if the patient can't raise their arm? What if the patient can't get out of bed? What if? Those questions will always be answered on the care plan. Good? Good. Isn't that cool? The whole system is made to answer your questions. The whole system. The whole nursing system is based on how do we answer those CNA questions. So in a very real sense, you guys are what is creating the need for the care plan. Okay. Yes, there's legal in there. And there, I'm oversimplifying it, obviously, because there's multiple nurses on multiple shifts. But to give you an example, in an ICU setting, I used to work in the ICU. In an ICU setting, we very rarely had CNAs, if ever. And that's because CNAs do normal. Remember, those are routine tasks on stable patients, right? The ICU, there's nothing stable. These people don't even blink right. Okay, there's nothing stable. So having a CNA isn't going to help me because what am I going to have you do? You know, go get me water? I mean, that's really all I can get you to do. There's very little. I mean, yeah, you can help me turn patients, but I still have to be there. Does that make sense? Right? So in a very real sense, CNAs have to work in very routine environments because of that. Well, in the ICU, our care plans were not nearly as extensive as what you would have on med-surg because I'm the one doing all the work. I don't have to indicate, you know, which side the patient needs to be on because I'm the one that's going to be moving the patient. Now, I'm not working 24 hours. So those care plans were written for nurses by nurses to keep all the nurses on the same page. But they were much shorter because nurse to nurse, I don't have to give you as much information. You're able to assess the patient as well. Nurse to CNA, you can't assess, so more information. Does that make sense? But this is why you're not going to see a lot of CNA openings in high acuity settings. High acuity means patients need a lot of care. So the mother-baby unit, the NICU, the ICU, CCU, hospice, we do, but those, believe it or not, are not considered high acuity in most cases. It's still very routine, right? The dying process is just as natural as the living process. We just want to keep their symptoms under control. Okay. Death is not scary. Death is actually something that everybody has to do. You don't get out of life without it. So it's not really as scary as people tend to think. The finality of it, I think, gets to people. But caring for dying patients, nothing like what Hollywood shows you. Yeah. Hollywood has crazy stuff, like people sitting straight up in bed after they're dead and all kinds of weird stuff, right? It doesn't happen like that. So, yes, you can have CNAs in hospice. Game show tomorrow. Tomorrow? No. Game show Monday or next week. I'm sorry. The first Thursday. Yeah. Because we haven't even got to Halloween. Yeah. I got to reacclimate, guys. Sorry. Yes, so game show will not be tomorrow. It will be a week from tomorrow, which is the day before your graduation. That's going to be important for you to kind of get a sense of what kind of questions you're going to get on that state exam. Okay. So mark your calendars. We will send out a text message. All right, real quick, and I mean real quick. How do we know what to do with each patient? We're going to follow the care plan, the whole care plan, and nothing but the care plan. While we're doing that, we're making observations, and we're going to report those observations to. Every skill starts with the opening. Every opening starts with a knock. That's right. We're going to greet the resident, address them by name, introduce ourselves by name and title, tell them what we're there to do, get their permission, close the curtain, wash our hands, get our supplies. Do not change that order. Cardinal rule here is don't touch the patient until your hands are clean. We have to decide if we need gloves. Remember, it's not skill specific, it's patient specific. You may need gloves to take somebody's pulse if they have open sores in the area. It's not based on the skill. So we are going to use gloves anytime we might potentially touch body fluids, personal skin, or non-intact skin. If we decide to wear gloves, what's the first thing they should touch? The patient, not the environment, not your supplies, the patient. Keep your gloves clean for them. Would you want dirty gloves in your mouth? No, or anywhere else? No. Remove your gloves correctly. Pinch up and then go under. You may, if you are going to use supplies, remember we do have a few skills that don't have supplies, but if we're going to use supplies, in most cases, we need a place to put them, and that's going to be a barrier. You can use anything for a barrier, but for the test, we're going to use a Chuck's absorbent side up. Remember that you have to have clean hands to get your supplies, and we're going to get our barrier first. So we're going to get the barrier, put it on the table, go back and get the rest of your supplies and put them on the barrier. Don't hold them up next to your uniform as you're getting the supplies because we don't want to contaminate them. One of the supplies you might need is a privacy blanket. We use this anytime the patient is uncovered or undressed. What do I not want to see? Knobby knees. Very good. It's used not just for privacy, though. It's also used for warmth because your patient might feel cold if we take that sheet away. They'll also feel a little exposed. Don't take the sheet away and then put the blanket on. The whole purpose is to keep the patient warm and covered. So we'll put the blanket on first. Don't snap it. Just lay it out and then pull the sheet down underneath so your patient stays covered the whole time. We also learned some linen rules. With linens, these are mostly repeats of stuff we have already learned. Linens can't touch your uniform. You have to have clean hands to get your linens. Don't snap or shake the linens. Clean rolls toward me, dirty rolls away. Nothing on the floor. Not clean, not dirty, nothing on the floor. One of the, and this is surprising to me, but one of the most missed checkpoints on all washing skills, whether it's hand care, foot care, partial bed bath that we're going to learn today, peri-care, catheter care, one of the most missed checkpoints is that when people are done cleaning something with a washcloth, they'll put it on the ground. They'll just drop it on the ground and then keep clean. They don't put it on their table. Nothing goes on the floor. And I can see why that might be attractive to people, right? They don't want to put something that's been used on their barrier. I understand the thought process there, but nothing goes on the floor. Nothing but your feet. Be careful there. That's why we use the barrier on the table. So we've got an area to put those dirty items. Good? Good. All right. Anything we take and don't use has to be discarded. Don't leave it in the room for later. Patients always have to be in the middle of the bed, no matter what. They have to be in the middle of the bed. You can't rely on side rails to keep your patients safe. That's not what they're there for. So in order to keep the patient in the middle of the bed, after you've turned them, you'll scoot them towards you first and then roll them away. Remain behind, your patient's behind. Okay. Washing rules, we're going to wash everything the same way. This is, I mean, We have a lot of washing skills, and we do them all the same way. We are going to check the water temperature with our wrist. It should feel warm, not hot, not cold, just warm. Who else checks it? Patient. What do you not add to the water? Soap, because we need water for rinsing, right? Whatever you wash, you rinse. Whatever you rinse, you dry. Don't get your surface wet, so protect the bed. If you're working on the bed, we're going to do that skill today. Protect the table with the chucks if you're working on the table. If you're doing foot care, put the chucks on the floor, but you're protecting your surface from getting wet. If you're going to apply lotion, warm it up first, then wipe off the excess. Now, if you're washing something, that means that you had a basin to hold the water. So we now have to know how to clean the basin. For the test, rinse it, dry it, store it. I don't care how you do it. Just rinse it, dry it, store it. But I want you to know the right process. Like this isn't graded on the test. They just want it rinsed, dried, and stored. But I need you to know the right process because I might be the body in the bed one day. Okay. So we're going to dump the basin, rinse it out, dump the rinse water, set it down, and disinfect it if necessary. You cannot hold the basin while you're disinfecting it. That negates the whole disinfection process.
You said on the test all they want us to do is rinse it, dry it, store it. Do they still want us to use a paper towel to pick it up, paper towel to open the drawer?
The only thing that the test requires is that you use a paper towel to open the drawer.
Okay.
You rinse the basin, dry the basin, store the basin. The only checkpoint is that you use a paper towel to open the drawer with. That's it. For testing, this is super, super simple. I want you to be a little smarter than the average bear. But yes, that's all that they care about. They're not grading you on using that paper towel to pick it up. I need you to know that because if you disinfect it and then you immediately touch it with those dirty gloves, what was the disinfection for? And that happens. Oh, that happens a lot. So why this is so important to me is my aunt had cancer and underwent chemotherapy, and we killed her immune system. She had no immune system, none. We killed it. That's what chemotherapy does. And I happened to walk in and I saw somebody, they had just cleaned her down below, Pericare. They had Pericare gloves on and they're putting her basin away. Pericare gloves. Now, my aunt has no immune system. So the next time you pull out that basin, what are we exposing her to? Yeah, and E. coli lives there. I mean, that could have been a death sentence. Do you guys understand how important that is? This is somebody's family member. Somebody loves this person. Even the most unlovable people, somebody loves it. Might be their dog, I don't know. Somebody loves them. Even the most unlovable people has somebody that would notice their absence. So whether you like them or not is kind of immaterial. Somebody does. So we probably ought to try real hard to keep them alive. Good? Makes sense? Yeah. I always tried to remember that, especially with the hard patients. You know, even if I don't like you, somebody's got to. Somebody, parakeet, goldfish, something. So I tried to adjust my perception of the person based on that. So even if I didn't like them, I tried to imagine that goldfish's life without that person and how it would be impacted. And just that one little bit will help you reframe your interactions with people. Yeah, I don't like you, but somebody does. Not sure why, but somebody does like you. So I'm going to respect that, even if I can't respect you. Does that make sense? Sometimes that can help you through some of those hard days. All right. And then we end every skill the exact same way with closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Environment's clean, bed's in low position, call light. Curtain, wash hands, document, wash hands again. Our cardinal rule here is to end skill with clean hands. I don't care how you do this. The order here does not matter. Nobody cares until you get down to cleaning your hands. Once you've washed your hands, please do not go back into the patient environment. You're going to re-cootie up. And then you're going to have to wash again. Okay. So once you get to hand washing, make sure everything else is done. So put this in an order you can remember. Do it the same way over and over and over again. So for me, comfort, curtain, call, light, clean. I mean, that's it kind of goes together, right? Comfort, curtain, call, light, clean. And when I go through that in my head, did I comfort? Yes. Did I call, light, curtain, clean environment? Okay, I'm good. I can move on now. But make it make sense for you. That may not work for you. All right. Pulse, normal, 60 to 100. We're going to count as long as care plan tells us to, and we're going to use the radial pulse, which is located at the very top part of the wrist. Use 2 fingers, not your thumb. Use the tips, not the flat part. Make sure you document. Dressing a resident, remember USA first. Undress strong arm first. That allows the garment to just slide off that weak arm. New garment just slides on the weak arm. Make sure they look good after dressing. Everything is buttoned or snapped right. The pants are over the butt. The toe seams are over the toes. Make them look good. Okay. Minimize exposure when you're dressing. Get everything you need before you undress them. That, I don't know why, but that is a frequently missed point on the test. People will undress the patient and then ask them, what do you want to wear? And go get their clothes. I mean, imagine that patient. That's a little intrusive. Does that make sense? So just be aware of that. There's not much to this. Just remember USA first and follow the care plan as to what you're going to wear. This is a mannequin skill. You're going to be doing this on the mannequin. She doesn't move like a real person. So you kind of have to work with this a little bit. Okay. However, you have to ask the mannequin, what do you want to wear? The evaluator is going to answer. So you're really going to talk to the mannequin. It'll make you feel weird, but that's all right. The evaluator is going to answer, and they're going to describe an outfit. There's 2 outfits on the supply shelf. You got to make sure you're getting the right outfit. Now, it's very obvious. They'll say, I want my blue shirt and my blue pants, or my pink shirt and my pink pants. I mean, it's very obvious, right? But make sure you're getting the right outfit off of that, because that's actually a graded checkpoint. Is that you got the right outfit. Good? Make sense? Yeah, but talk to the mannequin. Hand and nail care, this is a mini mani. You're going to soak the hand, wash the hand, rinse the hand, dry the hand. We'll clean under the edges of the nails with that orange stick, the slanted end of the orange stick, and we're going to wipe it off in between nails so we're not transferring. Then we're going to file the nails toward the center in one direction only. Warm our lotion, put it on, wipe off the excess, and clean up. That's all of nail care, hand and nail care. That's it. Then we have making an occupied bed. We're changing the bottom sheet half at a time. Keep the patient in the middle of the bed. You want them on their side so they take up less room, right? If you look at somebody, like if somebody's laying on their back, they're taking up a significant, like as wide as they are, they're taking up the bed. But if you look at somebody from the side, they're only this wide, right? So there's a big difference in the bed between this and this. So you want them on their side when you're changing their sheets, so you can get to as much of the sheet as possible. But if they're on their side, they need to be in the middle of the bed on their side, which means scoot and then roll. Then you just put the top sheet on, change the pillowcase out, remove the privacy blanket, and they're good to go. Sideline position. This is changing somebody's position. You have to know which side you're turning them to. That's a critical piece of information. If it says to turn them on their left side, they need to be on their left side, their left, not yours, their left at the end of the skill. So if you're turning them on their left side, and we're always turning people away from us, that means we're on the right side of the bed. Make sense? Because you turn somebody away from you. You need that piece of information, because otherwise you don't know which side of the bed to be on, and the rest of this makes no sense. So the first thing you need to know is, what side of the bed do I need to be on? And get there. Once you're on the correct side of the bed, furthest arm goes up, closest arm goes across, closest knee bent, furthest knee angled out. And then hand on the hip and shoulder, and you just roll them over. Super easy. Don't use a lot of force here. You will push them right off the bed. Super easy roll. This is a live patient skill. You guys all need to practice this with a real person before you get to the test, so you know how much force to employ there.
Knees, the knee closest to you bent upwards. Yeah.
Right.
Not,
Right.
not bent.
Right. Tent it. Tent it. Yep.
Why does the Sims position just say the left side and it doesn't mention the right side?
Okay, so Sims is a very different type of position. Let me explain what Sims is. So you're going to have to learn some, you're going to get into this in chapter 9 of your reading, homework reading, but you're going to have to learn some positions. So supine is on your spine, laying on your back. She is supine. Prone is the opposite, posterior up. You're laying on your tummy, your bottom is facing up, right? So supine is on your spine, prone, posterior up. But then you get into your side lying positions. So lateral is just on your side, just on your side, any side, pick a side, lateral is on your side. Sims is a very specific on your side, and it's left side with the knee, the right knee bent up. And this is so that we have direct access to your bottom. And your intestines are in the right orientation for what we need to do. So this would be for suppositories, enemas, colonoscopies. When we need to get to a certain area and we need unrestricted access, that's the position that we're going to be in, is our Sims position. Now, for me, the way I remember this, because I got some really funky ways of remembering some of these words, right? This is my sleeping position. I sleep on my left side with my right knee up. That's my sleeping position, right? So Sims is the name of a mattress manufacturer. So, or Simmons. So I think of Sims as the sleeping position, which is on my left side, right knee up. Okay. Fowler's is another position you need to know. Fowler's is when the head of the bed is up. So semi-Fowler's is kind of up. High Fowler's is all the way up, sitting up position. Well, fowl, F-O-W-L, is another word for chicken. It's a very old-fashioned word, but it's another word for chicken. But you have to be sitting up to eat chicken. So there you go. Fowler's is sitting up to eat chicken. I know, crazy little memory tricks. They work. They do work. All right. Once you get the patient rolled over on their side, so furthest arm up, closest arm crossed, closest knee bent, furthest knee angled, get them over on their side. You're going to put a pillow behind the back in the roll just to keep them in that position. One between the legs, between the knees and the ankles. One under that top arm to get it into a nice neutral position, and then adjust the one under the head. Head goes under the pillow, call light in the bottom hand. Foot care, just like hand and nail care, a little lower, nothing with toenails. So we're going to soak the foot, wash the foot, rinse the foot, dry the foot, lotion the foot. The whole reason you're there is to look at the foot. Put the sock and the shoe back on. Make sure that we've eliminated the wrinkles and clean up. Easy. As long as you can get up and down off the floor, this is an easy skill. For me, this is like the one I dread. This is the one I would get because my knees don't work anymore. I can't get down. You should have seen what we had to do to tape that video. It took, what, Jake, 3 or 4 takes.
Yeah, quite a few.
Yeah. And we ended up building a platform for him. We had to elevate his chair on a platform and for him to put his foot. We did all kinds of Hollywood magic went into that skills videos. Yes, he had to build a stage. Yep. Yep. So that was that was a lot of fun. So that was the last one we did because I hate that skill. But other than that, I mean, if you don't have a problem getting up and down off the floor, this is one of the easiest skills. There's nothing to it. Soak the foot, wash the foot, rinse the foot, dry the foot, lotion the foot, and look at the foot. That's it. Mouth care. It's brushing teeth, guys. Just make sure they're sitting all the way up. Protect their clothing. Wet your toothbrush. Put some toothpaste on it and brush. Whatever they got, top, bottom, front, back, tip of the tongue. Let them rinse. Dry them off. Don't forget that step. Don't leave them a drippy, wet mess. And then clean up. You do need gloves for this. We are working with body fluids. Respirations, don't tell them you're counting them because it does alter their respirations. In and out counts as 1. Normal is between 12 and 20. Don't stare at somebody without touching them, though. A minute is a long time, and you will get the title of creeper. Don't do that. Range of motion. We have learned range of motion shoulder. We are going to learn today range of motion hip, knee, and ankle. That's the first skill we're going to start with today. So all of these rules are going to apply. We're going to read the care plan. It's going to tell us what body part. It's going to tell us what exercises, and it's going to tell us how many of those exercises to do. We're going to follow that recipe. That's it. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. So you do whatever exercises are on the care plan for as many repetitions as on the care plan, on the body part indicated on the care plan. And these are absolutely the easiest skills on the exam. Each one takes less than 4 minutes. Super quick. Okay? Good. All right, so let's learn range of motion, hip, knee, and ankle. This is going to be on page 80 of your skills book. If you look at the side there, you'll see the principles involved. They're all spelled out for us here. Here's our overview of our principles. They're all spelled out for us here. We're going to follow the care plan, exactly what it says. We're going to do our opening, evaluate if we need gloves. Now, for the test, this is done on a live patient. I know that because of this. That means one of you guys are going to be exercised. You are probably going to be fully clothed for the test. Certainly hope so. And you're probably holding on to all of your own body fluids like a champ. So chances are you will not need gloves for this skill. But in a clinical setting, your patient might be in a gown and nothing else, and they might be incontinent. And if you're lifting the leg, there might be some body fluids there. Would you need gloves? Yes. So are you seeing that it's not based on the skill? Good. All right. And then we're going to do the closing at the end. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Bed's low in position. Environment's clean. Here's your call light. Open the curtain. Go wash my hands. Nothing new to learn. We've already learned all of the principles we need to know to do this skill. Step-by-step instructions are here. Care plan is at the top. No supplies are needed. But let's look at that care plan. Oh, let me go back. Let's look at the care plan. It says to provide the following range of motion exercise to the resident's right hip, knee, and ankle. Flexion extension. That's it. Just one exercise. And remember, flexion extension was up, down. It tells us to provide 3 repetitions of each exercise. So we're going to go up, down of the hip and the knee together. I'm going to show you why in a minute. And we're going to go up, down on the ankle. Do each one 3 times, put an opening in front and a closing in back. That's a whole skill. It's like 1 minute, maybe. And the opening and the closing takes way longer than the skill does. Way longer. So there's not much to this. It also tells us the resident's not able to help with the exercises. So in a perfect world, I would tell you what to do. You would do it. I would watch you do it, make sure you're doing it right, but you're doing the work. Perfect world. That's not what this is. Our care plan says our patient can't do that, so we're going to do the work. Now, hips and knees are always a 2-for-1 deal. Always. We do not raise a leg straight up to bend that hip. And I'm going to show you why in a minute. When you bend the hip, you must always bend the knee at the same time. So this, if you stood this patient up, it would look like they were walking upstairs. Okay. So what we're doing is lifting that leg and bending the knee up to the chest and back down to the bed. But when we do that, we see that the hip is bent and the knee is bent. Good? Good. Let me show you why we don't do straight leg raises. This. We have nerves going down. This is our spinal cord down here at the very bottom of your back. It branches off into 2 big nerves. Those nerves feed each one of your legs. This right here is the sciatic nerve. When you lift this leg in a straight leg raise, it pulls this tight like a rubber band. And that in some people can aggravate that nerve. And we call that sciatica. And nerve pain is way worse than muscle pain. Nerve pain is bad pain. And it's the kind of pain that you can't really get away from. So when you do this, when you stretch that nerve and you pull it tight, unfortunately, this pain that we're inducing can last for days, weeks, months, just from this one action, one time. So we don't do this. If we raise the leg, we have to bend at the knee. And what that does is it keeps this nerve from getting pulled super tight. It leaves slack in the line. Good? Make sense? Okay. And then we're going to go down to the ankle. We just foot forward and back. That's it. We're just bending the foot forward and back. That's all we're doing 3 times. But I don't want that heel to scrape against the bed while I'm bending the foot forward and back. So I'm going to lift that ankle up just a little bit to get the heel off the bed. Doesn't have to be off much, just a tiny bit. And that way, when I'm bending the foot forward and back again, it's not causing that heel to scrape. So here's our care plan. We're going to provide the following range of motion exercise to the resident's right hip, knee, and ankle, flexion, extension. Provide 3 repetitions of each exercise. The resident's not able to help with the exercises. So remember, our care plan for range of motion always tells us what body part, what exercises, and how many repetitions. We're going to do our opening, figure out if we need gloves. We're going to lift from below with a flat palm, supporting the extremity near the joint. Move slowly and smoothly all the way back to start. Flexion extension is up, down. We're going to do that 3 times. We'll ask about pain as we do this and then do the closing. That's it. So let's show you this video. Jake, range of motion, hip, knee, and ankle.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
Okay, I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, after washing my hands, we're ready to get started. The first exercise I'm going to do is bring your knee up to your chest and back down to the bed. I'll do all the work. All you have to do is let me know if there's any pain or discomfort. We're going to provide 2 points of support, one under the knee and one under the heel. And we're going to lift up and all the way back to the bed. Feel okay?
Yes.
Any pain?
No.
We're going to do it again. Up and all the way back. And one more. Up and all the way back. Feel okay?
Yes.
Okay, now I'm going to work on the ankle. I'm going to lift your leg off the bed just a little bit, and then I'm going to bend your foot forward and back. You should feel a little stretch. Please let me know if there's any pain.
Okay.
So I'm going to lift under the ankle. We're going to bend the foot forward and then back. Feel okay?
Yes.
We're going to go forward and back. Feel okay?
Yes.
One more, forward and back. Good?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Are you comfortable?
Yes, ma'am.
Environment is clean. Bed is in the low position. Here's the call light. If you need anything at all, just press the red button and we'll be happy to come help. I'm going to open the curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Those are easy skills. Any questions? No? All right, moving on to denture care. It's going to be located on page 96. All right, on page 96, you can see all of the principles that are involved in this skill. They're all spelled out for us here. We just went over them. You know them all. There's nothing new to learn here, guys. This is a fairly long skill. Somebody with your level of experience should be able to do this in 13 minutes or less. So it's a fairly long skill. It will be done on a live testing student. One of you guys might be the patient for this. Don't freak out. I'm going to explain it in just a minute, okay? But yes, one of you guys may be a patient for this. You'll be sitting in a chair. So for the exam, we have to read the care plan. That care plan at the top of page 98 or 97, sorry, tells us a resident with dentures is sitting at an overbed table with their dentures in a denture cup. So stop there for a second. Your patient is sitting in a chair. The dentures are already out of their mouth. They're in a cup. That's why you can be a patient for this. Nobody's taking dentures out of your mouth. CNAs do not take dentures out. CNAs do not put dentures in. Not a CNA job. The patient has to be able to do that themselves. If the patient cannot take their own dentures out, or if the patient cannot put their own dentures in, they do not wear dentures. We puree their food. You do not take dentures out. The reason is because if I have dentures on the lower jaw and I'm going to get them out, I have to put my fingers way back here at the very back edge of the dentures, and I've got to pop them up and forward to get them to unseat. Most of the time, they're held in with sticky denture paste. So to unseat, I've got to get back there, lift them up and forward. I can do that on myself because I'm not putting lateral pressure on that lower jaw because of the way my fingers are positioned. But if I do that to you, if I put my fingers in your mouth to get way back at the back to pop them up, these knuckles right here, these first knuckles right here, they have to press down on the jaw while my fingertips pop up. I have to have pressure to make that happen. And that can dislocate the lower jaw because you're not aware of how much force you're exerting. You have no gauge of the force. So you can dislocate a jaw. That's not something we should be doing. Now, on the other hand, the patient has to be able to put their own dentures in, because when you put dentures in, the instinct is to bite down to seat those dentures where they're supposed to go. Well, if you put your own dentures in, you're not going to bite yourself. I mean, you know where your fingers are at all times. But if I put your dentures in your mouth, my fingers might be in the way when you bite down. And because your dentures aren't seated yet, you have no tactile response to that. You can't tell that you're biting down on something. And I come away with a bloody stump. So CNAs do not put dentures in. CNAs do not take dentures out. That is not your responsibility. The patient does that. So for this skill, your patient is sitting in a chair at an overbed table with their dentures already in the cup on the tray. Your job, according to the care plan, is to clean the dentures and put them in a place, in a cup, for the patient to use later when they decide to use them. You're also going to clean the mouth those dentures came out of. That's denture care. That's it. We're going to take these dentures to the sink and clean them, put them back in the cup for storage, and we're going to clean the mouth those dentures came out of using that whole mouth care technique we already learned. Good? Questions? Our care plan actually tells us that the resident's denture needs to be brushed with toothpaste and the resident needs mouth care. The resident is stored in a denture cup after cleaning. So our care plan tells us, put it in the cup, not in the patient's mouth. The resident is not able to provide their own mouth or denture care. Guys, this is one of those skills that if your patient can do it, they will. They aren't going to want you in their mouth. They aren't going to want you playing with their dentures. These suckers are expensive. A set of dentures on average for a full set is about $5,000. That's expensive. And it's really, really easy for you to not pay attention, drop them, and break them. That's expensive. Your patient probably won't want you handling their dentures because they're afraid that you're careless. They don't know any different. There was there was a news article about this, I don't know, probably about 8 or 10 years ago. And I kind of laughed that it actually made the news. I mean, it must have been a really slow news day for this to make the news. But this one resident at it was either an assisted living or a nursing home. I'm not sure which. But staff members broke 12 sets of dentures. 12. Somebody would break it, she would get it fixed, and then somebody else would break it. And she'd get it fixed, and somebody else would break them. And she'd get a new set, and somebody else would break. It was just over and over. And she finally, for some reason, I don't know whether it was her family that got a hold of the news team or whatever, but she was so upset. 12 sets of dentures. So this skill is all about protecting the dentures. That's what they're going to grade you on, protecting the dentures. By the way, when you're in a facility and staff members break the dentures, do you know who has to pay for that? The facility. Yeah. We'd probably be a whole lot more careful if it was coming out of our paycheck, though, wouldn't we? Yeah. Now, if a facility had to pay 12 sets of dentures, roughly $5,000 a set, that's 60 grand in dentures. You think you're going to get a raise? No. You're not even getting a pizza party on CNA day. Okay. All right. Lots of supplies for this one, guys. No way around this. Memorize your supplies. There's a lot of supplies here. We're going to get to there.
Okay.
We're going to get there. I'm going to lead you there step by step. Okay. So there's two parts to this skill, and this is what really kind of messes people up a little bit on the exam. Students tell me that this is the hardest skill to perform on the exam. This is from the students. Students tell me this is the hardest one for them because there's two parts to it. You're cleaning the dentures and you're cleaning the mouth. So there's two parts to this skill, and it's a longer skill, but it does require a glove change in the middle. And it can get a little bit confusing for people because when do I change the gloves? What can I touch? What can't I touch? It gets really, really murky in there. So I'm going to try to lead you through this and tell you that they're not grading you as harshly as you think they are on that, but I want you to have some awareness of clean versus not clean. Good? Good. So we're going to clean the dentures and we're going to clean the mouth those dentures came out of. Now, you can do this in any way you want to. If you want to do mouth care first, knock yourself out. If you want to do denture care first, that's perfectly fine. Nobody cares which comes first. Let me say that right off the gate, okay? The way that I do it is quicker. We're going to clean the dentures first, and then we're going to clean the mouth the dentures came out of. It's quicker because you only have to clean the basin once. And I'm going to get into that in just a minute. I'll lead you there. But before I start showing you this and people go, but wait, can't I do mouth care first? Yes, you can. You can. But the way that I'm going to show you is a little bit quicker because it cuts down on your cleaning time. Okay. All right. So there's 3 different types of dentures. And I try to bring this up because a lot of younger people aren't aware that there are different types of dentures. This is what we call a full plate. All of the teeth have been replaced. This is a top plate because it has a palate. This is the part that goes up against the roof of the mouth. So all of the teeth plus the palate, this is a full set. I mean, this patient has no top teeth of their own. All of their teeth were replaced. But if somebody still has some healthy teeth in their mouth, we don't want to pull healthy teeth just to give them fake ones. So in that case, when people still have some healthy teeth, we create partials. This is a partial. You can see the teeth that were replaced, and you can see the cutouts for the teeth that still remain. There's usually hooks or clips that are going to clip onto existing teeth to help hold this in place. So this is a full plate. This is a partial. We're going to clean them the same way, but just so that you know there is a difference. Now, there's one more type of denture that isn't being used as often anymore, and that's called a bridge. A bridge is like a partial. It's only replacing some of the teeth, not all. But a bridge is a little bit different because it's just a little piece of the denture. It's not like this partial is like the whole horseshoe shape, right? A bridge is just a little piece of a denture that fits in a space and hooks onto other teeth around it. Most, and this is why you're not going to see this very often, most bridges are now permanently attached. So they don't come in and out like dentures. At some point, when you guys get to old age, at some point, we probably won't even have takeout dentures anymore because implants are becoming much more utilized. The cost is starting to come down a little bit. And with implants, they literally implant them. We don't take them out. They're treated like teeth. So when you guys get to be older, you won't have to deal with dentures very much. All right. So here's your answer. Why do we need 2 sets of gloves? What kind of gloves do you want in your mouth? Clean. So if we're going to go to the sink and clean the dentures, are those gloves clean after we clean the dentures? No. So do you want those gloves in your mouth? No. Even though the dentures were yours, it's still kind of gross. So we're going to clean the dentures. When we get all done cleaning the dentures and we've got them in a cup and we've stored them and we got everything back to the table, we're going to take those denture gloves off. We're done with dentures, denture gloves off. Then we're going to prep for mouth care, towel over the chest, toothpaste gets wet or toothbrush gets wet, get some toothpaste. Then we'll put our mouth care gloves on so we have clean gloves for mouth care. Good? All right. There's two ways that you can clean dentures. Our care plan told us to clean them with toothpaste. This is what we're most comfortable with. We brush our own teeth with toothpaste. It makes sense, whatever. But in most clinical settings, you're not going to use toothpaste. And that's because dentures are not the same as your regular teeth. Dentures are a polymer, a composite. They're made of different materials. Toothpaste is abrasive. It has little particles in it that literally scratch. That's what they do. It scratches the film off of your teeth. Well, we don't want to scratch the surface of the dentures. So in most cases, your care plan is not going to tell you to clean the dentures with toothpaste. It'll tell you to put them in a cup with some fizzy tablets. And those fizzy tablets actually break down all of the film and the bacteria and the enzymes and all of that off of the dentures. So you can just rinse them and use a soft brush to get any bigger particles off. So most cases, your patient is going to want the fizzy tablets. But the test tells us to use toothpaste. What should we do to know which we're going to use for our patients? We're going to read the care plan. That's right. Good. Do you guys see why class 1 was so important? Yeah, because if you don't understand the care plan, none of this makes sense. Good? Good. All right. We're going to use a special toothbrush to clean the dentures if we've got one. You can use a regular toothbrush. It's okay. But if you've got this, it's way better. And the test is going to give you this. Use it. So this part looks like a tooth. It's just a short stubby, but it looks like a toothbrush, right? It's got the same bristles, same size. We use this on the teeth part of the dentures, right? If it looks like a toothbrush, we use it on the teeth. This part is much narrower and it's tapered, kind of looks like a pyramid. And it's tapered for a reason. It fits in the channel perfectly. So this is designed specifically to clean dentures. This part goes in the channel. This part cleans the teeth. So when we get this ready, we're going to get it wet. We're going to put toothpaste on both sides. And we're going to clean the dentures with it. Now, you could use a regular toothbrush. It's perfectly okay. If that's all you got, use it. It's fine. Nobody cares. But for the test, you'll have this. Use it. It'll make your life a whole lot easier. This is one skill that you really should practice at home. If you get if you have dentures at home or you have Halloween, this is the best time, guys. Go get those Billy Bob teeth at the Halloween store. And you now have dentures you can practice with. I mean, this is the best time of year to get fake dentures. But if you get the practice kit, those of you who, I don't know who's got the practice kit, you're going to get dentures. Now, they're not real. Please don't put them in your mouth. They're not going to fit. But they have teeth that you brush, and it also has this groove, like the channel. So this is what we call a denture practice piece. My mom makes these for me. Isn't she sweet? We really are a family operation. Yeah. My oldest son is my patient. Jake runs all my tech. My mom makes the dentures. And we're definitely a family operation. All right. So when you're practicing this at home, you can just use a toothbrush to brush the dentures. You also need something to brush the mouth. Now, you can use a toothbrush for that too. Perfectly okay. The problem is that in real life, your patient has denture paste on their gums. That denture paste is going to get all tangled up in those bristles, and it's not going to be very good after a few seconds. So in a clinical setting, instead of using a toothbrush to brush the patient's mouth, we use something like this. This is called a toothette or an oral swab. It's soft, it's spongy. More importantly, it has 4 independent cleaning surfaces. I get this wet, put a little toothpaste on it, and I can use this side right here to swipe the paste off of one quarter of the mouth. Then I turn it, and I use this side to swipe the paste off of another part of the mouth. And then I turn it again, and I use this side to swipe the paste off. And then I turn it again, and I use this side to swipe the paste off, and I throw this away, so I don't have to clean it. So this is what we're going to use for the test. Now, this is a live patient skill. So you might be the patient for this. You have teeth. It's fine. You can leave your teeth in. Perfectly okay. I can use this on teeth as well. So we're going to use it like a toothbrush. But in a clinical setting, I'm telling you, if you've got a choice, grab these. They make cleaning so much easier for you. Okay, good. I'm going to pass these around so you guys can see what they are. And I'm going to pass the dentures around so you can see the difference between a full plate and a partial. Somebody.
What are we practicing? What exactly are we trying to improve here? Our motions?
Well, we haven't gotten to the actual denture cleaning yet. So that's what you want to practice. Because it can get a little bit, there's a lot of steps. A lot of steps. Remember I said this is the one that students say is the hardest?
I have a lot of residents who have like suction cup dentures. That just like suction on up there.
Yeah, and that's great, but they have to take them out. And it still will allow food particles and enzymes in between the dentures and the gums. And what will happen, this is a really sad story. I was assigned to admit a patient to hospice, and she was dying from a brain abscess. And they had done all sorts of antibiotic therapy and all. They had drained the abscess. It was horrible. I mean, it was truly horrible. But it was going to kill her because they were out of options. There was nothing more they could do. And I went in, and I wasn't prepared for this at all. Nobody had given me a heads up on this. Bless you. I went in, and this sounds awful, guys, and I'm sorry, but has anybody ever seen like Freddy Krueger? Okay. You know how he's got this hole? She had that. Her entire cheek was gone. And you could see into her nasal cavity. What had happened was she had dentures, and she had dementia, and they'd stopped using her dentures because she couldn't take them in or take them out, put them in. They'd stopped using her dentures, but she was pocketing food up there. Well, because there wasn't dentures, nobody was doing mouth care because I figured, well, she's just got gums. Who cares, right? There's no teeth. So I don't know what their thought process was, but nobody did mouth care on her. Nobody. So she had this food pocketed up there. And over time, food is going to decay. It breaks down. And it decayed and ate into her gum. And nobody noticed. She had dementia. She wasn't really talking. Well, then she stopped eating. And nobody really cared. Nobody reported it. Nobody checked on it. Nobody did anything. That abscess ate through her bone into her nasal sinus, and there's nothing there between your sinuses and your brain. I mean, there's literally a piece of bone that's probably about as thick as that index card. So it ate from her sinus into her brain and caused a brain abscess that ultimately killed her. Now, what killed her? The fact that nobody brushed her teeth, her gums. Nobody took care of it. And it killed this patient. But the real sad part for me was that nobody reported any of it. Nobody reported the fact that she wasn't eating. Nobody reported that they weren't doing mouth care. Nobody reported the odors that were coming out. Nobody reported anything. They just ignored it. And the first time that anything was done was when she started to have external visibility, when it was eating through her cheek. to the outside. At that point, somebody says, you know, that doesn't look right, and finally reported it. Well, by then, there was so much damage done on the inside that that there was nothing left. And it ultimately killed this lady. And that's sad that something this basic, we're paid to do the job our patients can't do. And if we're not doing that, we're not helping. And for that, the patient got to pay several $1,000s a month. So we drained her bank account dry too, by the way. That's horrible. That's criminal. We shouldn't be able to get away with that. So if you have to do mouth care, do it well, please.
Was that fault like on several levels, like including doctors?
Oh, it was, yeah, yeah. But unfortunately, in medicine, if you've got enough money, all of your problems can be erased, right? Yeah. I mean, that is our society, you know. It would be nice for people to be held accountable for everything, but it's just not always the way it works, especially if you don't really have family that can kick up a fuss.
What was that name of the rights? The
Resident rights?
yeah, the gum goober G word. OB word?
Oh, OBRA. OBRA, yes. OBRA, yeah. Yeah.
Were they there or were they advocating?
Well, OBRA is the law that governs CNA training standards. You're talking about JACO, I think. JACO, yeah, ombudsman. Ombudsmen are people, they're not there to look for problems. They're there to mediate problems that are brought to their attention. So an ombudsman isn't going to go in and check on the patient. So they're just there for the patient to complain, hey, nobody is brushing my teeth and I'm paying $3,000 a month and nobody's brushing my teeth. Now the ombudsman will go to the facility and say, hey, why isn't anybody doing this? Right? They're a mediator. Okay, OSHA protects you, the worker. And then we have JACO, or Joint Commission. Joint Commission, JACO, is what oversees facilities. They're there to make sure that everybody is doing their jobs, that, you know, kind of like consumer protection. That's really what they are all about, is patient consumer protection, but they're not going to catch everything. And they only show up at a facility once every 2 years. And when they're there, everybody is dotting their I's and crossing their T's, and administration is out seeing patients, and you're like, who are you? Who are you? Oh, I'm the DON. I've never met you before. Who are you? You know? Yeah, so it's not a real indicator of the type of quality that these people are actually receiving on a day-to-day basis. And a lot of times those inspections are scheduled. So we know, hey, next Tuesday, yeah, Joint Commission's in the building, everybody on your best behavior, you know, but that's not really what it's supposed to be. If I ran the world, but I don't. All right, so we're going to use a denture brush and a toothette for cleaning. Both of them, we're going to use the same way. We get them wet first and then put toothpaste on them. If you don't wet them first, the toothpaste globs. It's not going to spread well. So wet, whether it's your denture brush or your toothette, doesn't matter. Wet it first and then put toothpaste on it. But once we've got toothpaste on our item, whatever that item is, whether it's a toothbrush, a toothette, a denture brush, doesn't matter. You got to have somewhere to put it because you still have to put your gloves on. You got things to do. So you got to have somewhere to put that prepared brush. And we're going to use an emesis basin for that. So we get our brush prepared and we just set it in the basin just to hold it. Because what we don't want is for that brush to get put on the edge of the sink. That sink is not clean. So we're going to, instead of just laying it on the edge of the sink, we're going to put it into an emesis basin. All that basin's going to do is hold that brush. It doesn't do anything more right now. It's just holding the brush for us. It's fine. Okay. Now we're going to take that basin to the sink, and our dentures, wherever they are already on the side of the sink, because when we did our opening, hi, Miss Jones, my name is Patty. I'm your CNA today. I'm here to clean your dentures. Is that okay? I'm going to close the curtain and go wash my hands. So I'm going to the sink. I'm on my way to the sink. So on the way, before I go to the sink, I'm just going to pick up that denture cup. I can touch the outside of the denture cup. It's not clean. Your patient took their dentures out of their mouth and put them in the denture cup. It is not clean. Okay. I can take this to the sink. I'm going to put it on the edge of the sink and I'm going to wash my hands. Now I have clean hands. My dentures are at the sink. They're ready to go. I can't touch the dentures without gloves. I can touch a cup. It's fine. I can't touch the dentures without gloves. So I've washed my hands. I'm going to go get all of my supplies, get them ready. I'm going to prepare my denture brush, put it in the basin, and I'm going to bring it over to the sink. And I'm ready to clean. Now, there's something else I need to bring with me, though.
That's a basin, right?
Yep.
Okay.
Yep. This, it's a basin is just anything that can hold liquid, right? So this is a basin. This is also a basin. So what kind of basins are they? Well, this one we usually use for bathing. So we call it a bath basin. This one is called a kidney basin because it's shaped like a kidney, but it's also called an emesis basin. Now, an emesis is a fancy word for vomit. So see how this is kind of curved here? It fits nicely here. So if I'm going to throw up, this is a nice, easy place to do that. In reality, right, it's called an emesis basin, and in theory, that would work. This doesn't catch nothing. So in reality, even though this is called an emesis basin, we don't use it for that. We use the bath basins because they're bigger, you know. But that's why this is called an emesis basin. Does that make sense? Yeah. Remember I said in healthcare, everything has two names? Yeah. All right. So keep your brush clean. Now I told you we needed one more item, right? We need a washcloth. The reason that we need a washcloth is we're going to put it in the bottom of the sink. When I'm cleaning these dentures, they're going to get awfully slippery, and I've got gloves on. I'm not going to be gripping them, really well. They're likely to fall out of my hands, and this is how we end up breaking 12 sets of dentures, right? Not a good thing. So when we are cleaning dentures, we know they're likely to fall. That's just mechanics. So we're going to put a washcloth on the bottom of the sink to provide a softer surface. That way, if they do fall, they're less likely to break. Now, if we can get that washcloth over the drain, that's best, because that allows the water to kind of pool up. And now we've got a pool of water with a washcloth on the bottom. So the pool will break the fall, and then the washcloth provides a softer surface. Does that make sense? This is the critical checkpoint on the exam. This is the one checkpoint you don't want to forget. Because then we end up breaking 12 sets of dentures, and we don't get our pizza parties. Okay. We're going to use cold water only. Cold water only. Now remember, we washed our hands, we got our supplies, we got everything ready. We don't want to touch that faucet. So we're going to use a paper towel to turn the faucet on. Doesn't matter if you put your gloves on before you turn the faucet on or after you turn the faucet on. I don't care. Nobody cares. It doesn't matter because you're using a paper towel. You're using a paper towel. It's fine. Whenever you want to put your gloves on, go for it. Good. Cold water only. You don't want to use warm water on dentures because there's a principle. Those of you who go on for microbiology will learn this. Heat coagulates proteins. Now, what that means for us as CNAs is if you use hot, it's going to make the stuff we're trying to remove stickier and harder to remove. That's no good. So cold water to clean dentures. All right. Wear gloves when you handle dentures. That's a no-brainer. I'm not touching anything that came out of somebody's mouth without gloves. That's really icky. So wear some gloves when you do this. First thing your gloves should touch, though, is, or in this case, what came out of the patient. So we'll put our gloves on before we get our dentures. And then you're going to brush. Brush what you see. Brush the top, brush the bottom, brush the groove, brush the teeth. Just brush. All surfaces should be covered in toothpaste. Doesn't matter how long it takes you to do it. 30 seconds is plenty. Move along. You got 13 minutes to get this skill done. You don't have to take all 13. Move along. All right. One of the other big checkpoints for this skill is that dentures can only be in one of two places. Either in the cup or in your hand. There is no option C. Dentures must be either in the cup or in your hand. You can't set them in the sink. You can't set them on the side of the sink. You can't put them in the trash can. You're either in your hand or in the cup. That's it. Now, I need you to understand that because I'm about to break that rule. Okay. There is another potential option. Once the dentures are clean, okay, we've got our clean. Now, remember, this only applies to clean dentures. Once the dentures are clean and rinsed, if you have two sets of dentures in here, if you've got a top and a bottom plate, and you need to clean the second one, once the first set of dentures is clean, you can put those in your emesis basin because it's still clean. The initial one that is clean. So you cleaned it. You took the first set out. You don't have to do this for the test. Test only has one. That's it. Okay. But you took the dentures out of the cup. You rinsed them off. You brushed them. Toothpaste everywhere. You rinsed them out. You can't put it back in the cup because that water's dirty. What we're going to do is just rinse the cup out, get clean water, put them right in the cup. Perfect. We're good. No problem. But if there's another set of dentures in there, that doesn't work. What do you do? In that case, it's a very specific case. Very specific case. Those clean dentures that you just cleaned, the first set, you're going to put in the emesis basin just to hold for a minute. You're going to take the second set out, clean them, dump the water, rinse the cup, get some clean water, and put the second set of dentures in, and then the first. Good?
Slight question there. So when we are getting that basin, initially, that's like part of your opening pretty much when we're gathering supplies.
Right.
And that's what we're using to transport that, what was it, the brush. You are putting the cream, whatever, the toothpaste on the brush and then putting that on the basin that you're using to transport, to put on your barrier.
Okay, so let me walk you through this real quick.
Sure.
I'm going to verbally go through all of this. So, good morning, Ms. Jones. My name is Patty. I'm your CNA today, and I'm going to be cleaning your dentures. Is that okay? Close curtain. Take the cup to the sink. Put it on the side of the sink. Wash your hands. Everybody with me so far? So, denture cup at the sink. Clean hands. Go get a barrier. Put it on the table. I'm going to get my emesis basin, my toothpaste, my denture brush, my toothette, a cup of water, a towel, a washcloth, and 2 sets of gloves, and put all of that on my table. I'm going to pick up my denture brush, get it wet in the cup of water, put some toothpaste on both sides, and lay it in the basin. I'm going to grab 1 set of gloves, my washcloth, and my basin, and go over to the sink. Put the basin on the side of the sink. Put the washcloth in the bottom of the sink. Get a paper towel and turn my cold water on. Throw that paper towel away, get my gloves on. Now I'm going to grab that denture out, pick up my denture brush that already has toothpaste on it, and I'm going to scrub all surfaces, everything. And I'm going to rinse. Now that denture can only be in my hand, nowhere else. If I only have one denture to clean, well, I'll clean out the cup and put that in the cup, no problem. That's easy. But if there's still another denture piece in that cup, now I got a problem. Because I can't put this denture in the sink. I can't put it on the side of the sink. So my only other option is in that emesis basin, temporarily, for a second. Clean the second denture, clean the cup, put the second denture in the cup, put the first denture in the cup as well. You won't have to do that for the test. Test only gives you one. Because where do those evaluators want to be? At home in their pool drinking their margaritas. They do not want to be watching you do this. Watching a second set. I saw the first one. I'm good. Let's just move on, right? So for the test, you only have one.
Yeah.
But you need to know what to do with two, because most of the time your patients aren't just going to have one. They're going to have two. But I want you for the test to remember what I said. Dentures can only be in one of two places. The cup or your hand. Okay. Make sense? Good? All right. All right, so we'll rinse that cup out, fill it with cool water. We're going to put the dentures in it and put the lid on it. Now, our care plan told us to store the dentures in the cup because I'm going to follow that care plan. And it also tells us that the dentures are stored on the over bed table or bedside table. Okay, so I'm going to put the denture cup over here. But that denture cup has just been rinsed. It's wet. I don't want to put a wet cup on a furniture surface. Grandma would yell at you because it's going to warp it. So we're going to put a coaster underneath, just a paper towel, just something to catch that water before we put the cup on the bedside table. Good. Then we can take our washcloth, wring it out, put it in dirty linen. We don't need it anymore. We are done with denture care. But we still have, right? We took the cup and brought it over here on a coaster. We took the washcloth out of the sink and put it in dirty linen. Good job. But we still have that emesis basin on the side of the sink holding the denture brush. It's still over there. You are going to be doing mouth care in just a second. Your patient needs somewhere to spit. They need that emesis basin. You can't leave it at the sink. You need to bring it back to the table with you. Everybody good? Questions so far? Once I get that emesis basin back over to the table, I'm done with dentures. My denture care part of the skill completely done. So that's a good time to take off the denture care part of the gloves. So those denture gloves come right off. Now I have to do mouth care. Mouth care, I need to put a towel over the patient's chest. I need to wet the tooth at. I need to put some toothpaste on it, and I'm going to set it right in that same basin. There's nothing wrong with that basin. It just held a brush earlier. It's going to hold this now. Perfectly okay. No worries. So I'm going to put that prepared toothette in my basin, and I'm going to put my new set of gloves on, because what's the first thing my gloves should touch? Not all that. So does that help you understand why we need two sets of gloves?
Yep.
Because nobody wants dirty gloves in their mouth.
Yep.
And then you're just going to brush. Just brush. Whatever they got. Just brush. He was not impressed. Yeah. That is my mini-me. All 6 foot of him. He is. Yeah. You do not have to. And that's a very common question. You do not have to, because it's the same patient's cooties. It's their dentures, it's their environment, it's their mouth care. We're good. Okay. But after the skill, when I take my gloves off, do I need to wash my hands? Because we don't want to take his cooties anywhere else. I really wish that cooties were visible. If cooties were visible, you guys would be a whole lot better about hand washing. Everybody would. Yeah. If cooties, that is probably their best ecological adaptation, right? They're invisible to us.
It also makes life worse. If you ever play with a black light, then you start
Oh, yeah.
with surfaces of anything.
Yeah.
Yeah.
Yeah. Don't do that. Years and years ago, I used to teach a class called Health Science Concepts that you had to take before you took a phlebotomy or EKG. It was just a basic health class. And that's one of the things that we did. We spent an entire day on hand washing. Like here we have 5 minutes. I had an entire day of hand washing. So there was this lotion that you would have the students put on, and you would lecture for like a half hour. And during that half hour, there's you'd go on break, there's snacks and things. And then after break, you would have them wash their hands. So I've just taught everybody about hand washing. And after they put the lotion on, after I've talked for 15 minutes, everybody has forgotten that they put that lotion on. So you go on break, and then you wash your hands after break. And after break, after that hand washing, I took a black light and shone it over their hands so they could see all the areas that they missed. And everybody misses like a ton of areas. But then I would shine it over the room, and it would glow like the Milky Way. I mean, they're everywhere. It was astounding. I had to stop doing it after a while because it doesn't ever fade. So after like 4 classes, I mean, this place looked like the Texas Chainsaw Massacre. I mean, I had smudges on the ceiling. I couldn't figure out how did they get there? No clue. But it really illustrated just how mobile pathogens are on our bodies. And it was an amazing experiment to do. I learned a lot. All right, so remember, you're going to leave the patient's mouth clean. So here are our important checkpoints. You want to make sure you put a washcloth in the bottom of the sink when you're cleaning the dentures. You want to use cold water only. You're going to use a denture brush and brush both sides of the dentures, and then leave it in a cup of cool, clean water with a coaster underneath, and then brush our teeth. Okay. Good. This is a longer skill. You have 13 minutes to get this done. And it really is 2 parts. You've got the part where you're cleaning the dentures, and then you've got the part where you're cleaning the mouth. And you've got to make that transition. Now, they're not really grading you on that. If you pick up the basin without gloves, it's fine. It's fine. If you prepare the patient's toothbrush with the denture gloves on, it's fine. I'd prefer you not, but it's fine. They're not grading you on infection control the way you think they are. So cut yourself a little slack on this one. But this does seem to be the hardest for the students. Okay? I'm going to make it look easy, guys. I've been doing this longer than most of you have been alive. I'm going to make this look easy. Don't be fooled by that. This is one you really do need to practice. Okay? All right, Jake, take her away. Good afternoon, Mr. Jones. How are you?
I'm well. How are you?
Wonderful. My name is Patty. I'm your CNA today, and I would like to help take care of your dentures and perform mouth care. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to take your dentures to the sink to clean them.
Okay.
I'll bring the denture cup to the sink on the paper towel. We're going to set it on the side of the sink and open it, placing the lid beside it, and then wash my hands. After washing my hands, I'll get my supplies. We're going to start with a barrier. This is going to provide a clean place to put our clean supplies. So we'll spread the barrier out on the table with the absorbent side facing up. And for this skill, I'll need a towel and a washcloth, being careful not to let the supplies touch my uniform. I'm just going to go gather the rest of your supplies. I need a toothette, a denture brush, and toothpaste, along with an emesis basin and a cup of water. We'll set these on the overbed table. And I need 2 sets of gloves. Okay, I'm going to get the denture brush ready. We're going to wet it and apply just a little bit of toothpaste on both sides. Set it in the emesis basin right now. I'm going to take the washcloth, a set of gloves, and the emesis basin holding the denture brush to the sink. Mr. Jones, I'll be right back. I'm ready to clean the dentures, so I'll set the prepared denture brush in the emesis basin on the side of the sink. I'm going to place the washcloth in the bottom of the sink over the drain and put my gloves on. I'll take a paper towel and turn cold water only on because we only wash dentures with cold water, and we're going to throw that paper towel away. Now I can clean the dentures. I'm going to take them out of the denture cup and rinse them off, making sure that I hold them over the sink at all times. I'll take the denture brush, and the small end of the denture brush is going to clean the groove part of the dentures. So we're going to clean that whole groove, all areas, and the palate. Then we'll turn the dentures over, being careful to hold them securely, and use the other side of the denture brush to clean the teeth part of the dentures. We want to make sure that we cover all surfaces. Making sure that we hold it securely. And then we can rinse the denture brush and put it back in the emesis basin for later use. We're going to rinse the dentures off, removing all of the toothpaste. We'll take the denture cup, dispose of the water, rinse it out, and fill it with cool, clean water, placing the dentures inside, cover it with the lid. We can throw this away and get a clean paper towel to place underneath it. I can turn the faucet off, and we're going to go put this on the patient's bedside table. I'll place this denture cup on your bedside table over here for use later. Now I can remove the washcloth and place it in dirty linen. Now I'll bring the emesis basin holding the denture brush over to the overbed table and take the denture brush out and set it aside. Now I can remove my gloves. I'll throw these gloves away. Mr. Jones, I'd like to place this towel over your chest while I perform the mouth care portion of this skill. Is that okay?
Yes.
I'll get the toothette ready. We're going to get it wet. Put a little bit of toothpaste on it. And then hold it in the emesis basin while I put my gloves on. Okay, Mr. Jones, I'm going to brush all areas of your mouth, the top, the bottom, the front, the back. So I need you to open up wide for me, please. I'm going to start in the back, on the top, both sides, and then the bottom in the back, the front, and can you bring your teeth together? Thank you. Okay, thank you very much, and we'll rinse. Okay, pour the rest of the water in there. And just make sure that your mouth is nice and dry. Okay, I'm going to place this in dirty linen, clean my basin, and then clean my work environment. I'll be right back. We'll take the basin to the sink and dispose of the contents into the sink. We'll then rinse the basin and set the basin down in the sink. We'll use a paper towel to pick it up, a paper towel to dry the inside, a paper towel to dry the outside, and then one more for the drawer. On the way to the drawer, we'll pick up the denture brush and the toothpaste, placing them in the emesis basin for storage. The supplies away, we'll use a paper towel to open the drawer. We're going to put the basin, toothpaste, and denture brush in the drawer and then close it with the paper towels, and we can then throw the paper towels away. And now I'll dispose of all of my disposables. The cup, the wrapper, and the toothette, along with the barrier. These will go in trash. Now I can remove my gloves. We'll throw the gloves away. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Your environment is clean, your bed is in a low position, and you're safe. Let me give you your call light.
Okay.
Here's your call light. If you should need anything at all, just press that red button and we'll be happy to come back and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. Any questions? Questions? No? All right, let's go ahead and take our break. When you get back, we have 2 more skills to do. And potentially, I'm not sure yet, I'm going to try to bring in blood pressure. So we'll see if we can put that in. Go ahead and take your break.
because they just called. Okay, Peyton's calling them back, but we just got a break, so I told you to go ahead and call. Yeah, Peyton won't do this little. Yeah. Yeah. What's on Ray doing? Oh, hold on, we'll call him. Bye. Hello?
Hmm.
Good. Hi, how are you?
That's awesome.
The two intellectuals.
Give me a second.
That sounds amazing. Hey, I may, there's a possibility I may need you to do a couple t-shirts for me.
Okay.
For my girls' trip.
It's not a problem. I gotta do some I get more Julie shirts done too. Keep forgetting we have those other ones that I've got to complete for her. For me, whiskey goes in, nonsense comes out.
Lately, Jason's been saying, I drink beer and I know things. That's what I do.
So you have watched Game of Thrones.
Actually, he hasn't, which is, I think he saw it somewhere on Facebook
Yeah.
and he adopted it.
There's no way that hasn't been.
Yeah.
Okay.
Oh my God.
Excuse me. The first day of class, you guys offered us some coffee. Is that still a thing?
Absolutely. Everything in the back is available for you. Yes.
So there's also creamer in the fridge if you'd like any.
Mm.
Or even still, when they start to feel it, then you buy.
Mm-hmm.
Walmart's about to drop 25%. 40% of their employees receive federal government, which should not happen.
Yeah, I agree. They get tax breaks and subsidies and
It's not that their employees are getting that. It's not that. It's the fact that we live in a world where that's necessary.
right.
If you're working full-time,
But they also get tax breaks and subsidies.
Yeah. and they're going to get that. Well, they're going to get more of those.
Oh yeah.
I checked by on Saturday for orders and stuff. I was wondering how this 3-kid one came in. I didn't see it, but it was 6 o'clock on Saturday night.
Oh.
I was wondering why it showed so far overdue. Is that true?
I don't know.
For chapter number 6, I got an 85 on it.
Okay, and your name?
Peyton.
Peyton. Thank you.
You're welcome.
Thank you. Okay. Any questions on anything we've gone over so far? Hold on one second.
For the exam, the denture toothbrush, did we throw that away? Or do we have to store it? Or
For the test, they'll want you to store it.
okay.
The denture brush, the tooth that you'll throw away.
I just want to know what page, how to register for the state exam was on.
There is in your book, there are instructions, but you'll probably want to go back and watch the last 45 minutes. If you, yeah, but as far as step-by-step instructions, the most updated ones are going to be on the live. Yeah. You're welcome. All right. Let's move on. Just remember that the practice kit is available to you, and it does have everything that you need to practice. It has the denture brush, the toothets, the denture simulator, the emesis basin, the everything you need to practice is in that kit, along with the gait belt, which is the next thing we're going to be covering. So the lecture I'm about to give you will start on page 63. We're going to talk a little bit about energy conservation, because this is something that is not intuitive. I have to kind of bring your attention to this. It's not something that most people will think about on their own. So all the notes we're going to talk about is on page 63, but let's talk about 2-year-olds. My favorite age. 2 to 3, I absolutely love them. They're misunderstood. They are totally misunderstood creatures. If you've ever seen a 2-year-old, they do not sit still. They will bounce up and down for no reason at all. They just bounce. And it's because they have a ton of energy to expel. But you don't keep that level of energy throughout your lifetime. Now, have you ever tried to explain to that bouncing 2 or 3-year-old that you don't have the energy to play with them right now? Have you ever tried to have that conversation? Do they ever get it? Okay, that's real. They can't get it. You trying to explain it to them is absolutely futile. They can't get it because they have no frame of reference. All they know is what they've experienced, and all they've experienced is high energy. So how in the world do you expect them to understand that you don't have that energy? It's futile. You're never going to get them there. It's more important that we try to understand, because we have a frame of reference, that we try to understand where they're coming from. Everybody good with that? You understand that? Okay. Your energy level does not stay that high, and it actually peaks at around 2 or 3 years old. That is the highest energy you will ever have in your life, somewhere around 2 or 3. It goes downhill from there, and I'll prove it to you. 12-year-olds still have a ton of energy. Man, they can go out, they can skateboard, they can play basketball, they can play video games all night, slumber parties, stay up all night. They have tons of energy. But you put that 12-year-old in charge of that 2-year-old for one afternoon, who wins? 2-year-old every day. That tells you right there that your energy level has fallen from when you were 2 to when you're 12. Now let's go out to 22. 22-year-olds, they'll shop till they drop. They go out at night looking fabulous, wonderful, but you do not have the same energy level you did when you were 12. Let's go out to 42. Now 42, we're shopping till we drop, but that's at like 3, and we're not going out tonight. Now let's go out to 62. 62, we're starting to think about retirement because there's simply not enough energy to keep up with all the work requirements and the home requirements. We're slowing down. We're getting tired. We're putting our feet up for 10 minutes before we make dinner because energy. Now, what do you think your energy levels are going to be like at 82? Very low. Now, we have to understand that this is not universal. There are some 90-year-olds that will run circles around me. I understand that. But those aren't the ones we're taking care of. Those are the ones living their best lives. Those are not our patients. Does that make sense to you? You guys get it? Okay. So this is our energy graph. And I want you to remember when you tried to explain to that 2-year-old that you did not have enough energy to do what they wanted you to do, they didn't get it. Guys, remember that? You tried to explain to them and they didn't get it. This 82-year-old, when you go in and you say it's time for a shower, they're going to say, honey, I don't have the energy for that. And you're going to go, what do you mean? All you got to do is sit there. I do all the work. What do you mean you don't have the energy for it? What does that even mean? You're not going to get it because in this situation, you are the 2-year-old. You're not going to get it. You are going to try to insist that they have enough energy for this. They don't. They're telling you they don't. And yet, for some reason, we don't think that we should listen to that. We don't want to accept that as an answer. All you got to do is sit there. Anybody ever have the flu? Laying in the bed for 3 days, feel like you're dying, wishing you would die, right? And eventually you feel like, I've really got to get a shower. Maybe I'll feel better if I get a shower. And you get undressed, and by the time you get undressed, you're done. Like there's no energy for the shower. Like you've already wiped yourself out just getting ready to shower. Or even worse, you get under the spray and all of your energy goes right down the drain. And now you feel like you're about to pass out. Right? Right here. That's what it's like to shower right here. And when they tell you they don't have the energy, they know what they're talking about. They're inside their bodies. But us on the outside, we're healthy. We think, oh, you got energy for a shower. What do you got to do? You just sit there. I'm going to do all the work. Go ahead. Just get undressed. Don't argue with them, guys. They're telling you the truth. We got to believe them. So what we have to understand is that energy levels, as they decline, are going to affect your patient's willingness or ability to do tasks that you take for granted. So if this is all the energy we have for the day, let's think about all the things that we have to do that's going to use that energy. So a good frame of reference, a good thing to think about here is if you can say this sentence, if you've ever been too tired to blank, it takes energy. Have you ever been too tired to work? Okay, so working takes energy. We knew that one. That was a gimme. Have you ever been too tired to eat? So eating takes. Have you ever been too tired to talk? Yeah, Mondays and Wednesdays when I'm done teaching, in all seriousness, when I'm done teaching, when I go home, I don't want to talk. I'm worded out. I'm good. And my husband, thankfully, knows that this is not a good day for me. I need some time to decompress a little bit, right? You have to think about all of the things that you do that you don't even really think about. Here's one. If you've ever had a cold and you had to struggle to breathe, you know that breathing takes energy. Now, it's not something that we really think about, is it? Digestion takes energy. Maintaining your body temperature takes energy. These are things that we don't even think about, right? But if we only have this much energy and we got to like living, just existing is going to take some of that energy. So when we look at all of the things that we do every single day that takes energy, and we know that our older patients may not have much, especially because they're fighting something off, illness, injury, age, it'll help you understand a little bit more about their mindset, their physical ability. So when you say, hey, do you want to shower? And they go, no, You stop labeling them as non-compliant. They're not non-compliant. They're just energy deficient. Does that make sense? Do you guys have a little bit better reframing of that? Okay, so why am I even talking about this? Why do we care? We care because energy is finite. You can't go, I wish you could. You can't, I know that Red Bull has you convinced otherwise, but you cannot go to the store and buy energy. Okay. There's a whole industry out there that's convinced you can, but you really can't. But let's think about some things that you might not have really thought about here. If I'm going to get up out of this chair, I get up out of the chair. It's no big deal. You get up out of the chair. It's no big deal. You just stand up. Took very little energy. But that's not how our older people stand up. Our older people do this. Oh, nope.
Oh, you're doing that really
Right? How much energy, yeah, actor in my other life, how much energy did that take? That took so much more energy than if I simply stood up. Now, what's the difference? There is an inverse relationship between strength and effort. If we have high strength, it only takes a little bit of effort. But if our strength is low, what is that going to do to our effort? Makes it go up, right? There's an inverse relationship between these two. You guys are all young and strong. It doesn't take you a lot of effort to do these daily tasks. But what if you aren't strong? Remember, we learned in class 4 about the changes of aging, and we learned that some of the changes are musculoskeletal. Our muscles decrease in size and strength. Our nerve impulses decrease. Our endocrine system isn't producing as much energy for us, right? With those hormones that we need for energy. So this can become crazy hard. This can become daunting. Now, if it took me that much energy to get out of the chair once, let's look at how many times I have to do that during the day. So the first thing I have to do is get up out of bed. And then I go to the bathroom and I sit down, and then I have to get up off of the toilet. And then I go back to my bed and I'm tired, so I'm going to sit on the edge of the bed to get some energy before I get dressed. And I'm going to stand up and go to my dresser to get dressed. And then I'm going to go to the dining room and sit down to eat. Then I'm going to stand up and walk back to my room to go to the bathroom. That's all in the first hour of the day. And every one of those get-ups took that much energy. By the time I get to the afternoon, there's nothing left. The tank is empty. And this is why a lot of your patients don't eat at night, because eating takes energy. And we've used up all of our energy during the day. So what do you think is going to happen to tomorrow's energy levels if we're not eating well today? That's right. This is a perpetual downward cycle that can lead to failure to thrive in our older patients. So what do we do about it? Well, if we can use some of our strength, we can reduce some of their effort. We're going to let them borrow some of our strength. Remember, strength and effort are inverse. So if we can let them borrow some of our strength, they don't have to put forth so much effort, and now they can save some of that energy for use like eating later. Does that make sense? Good. That's what using a gait belt is all about. Gait belts are not about safety. Everybody thinks gait belts are safety. That's not what they're there for. Gait belts are a way to transfer energy from one person to another. You guys good with all that? Make sense? Okay. So this is a skill we're going to learn, ambulate with a gait belt. Here are our principles down here. They're all spelled out for us here. Test specific information. This skill should take somebody with your level of experience 5 minutes or less. Easy, quick, super simple, as long as you understand the principles involved. All right, so we need to learn a new principle here. This is our last one. Shoe rules. So after today, you now know everything you need to know on that back wall. Cool. Remember on day one, you guys all looked at that back wall and you went, and now you can recite them all to me. You just did earlier. You know them. So this is our last one. It's all smooth sailing from here. Okay. So let's learn shoe rules. Page 67 is our step-by-step instructions, and our care plan is at the top of the page. Our care plan tells us ambulate the resident at least 10 steps. Use a gait or transfer belt. The patient will be sitting in a chair at the side of the bed with shoes on. That's awesome, because now you don't have to bend down to put somebody's shoes on them for the test. They're already going to be wearing shoes. This is why for the test, there is no uniform requirement. There's no clothing requirement that you have to wear other than closed-toed shoes. So if you want to go in jeans, that's fine. If you want to wear scrub pants, that's fine. Leggings more comfortable, go for it. Whatever you want to wear is perfectly okay, but you have to have closed-toed shoes because of this skill. Good? Good. All right, it says patient is able to walk, but needs assistance to stand. We're going to loan them some of our energy to make that happen. But they can walk. So if you're the patient for this, you're not going to be an 80-year-old person. You're going to be you. You're going to walk like you walk. Okay, not a 90-year-old person, you. All right. Step-by-step instructions are going to tell us how to do that. But let's talk about this. Shoe rules. Slipper socks are not enough. And a lot of you have probably been patients at a hospital, and you got a hospital gown and a set of slipper socks. And we get so excited over those slipper socks. I don't know why, but we do. We get excited over them. And we put our little slipper socks on, and now we can walk, and we're not in danger of slipping, which is a fallacy. You actually are still in danger of slipping because those things twist around. And now the dots are on the top of the sock and not the bottom of the sock. And you probably also slip anyway. The other problem is they don't have heels on them, so they don't stay where they need to stay. But there's a way bigger problem with slipper socks than slipping. Those of you who were a patient at a hospital, did you ever get out of that bed and walk anywhere with those slipper socks on? Did you go to the bathroom?
Oh, yeah.
Do you know where most pathogens are located? In the bathroom. And most of them have made their way to the floor of the bathroom. Now, the other issue is that sometime during your stay, your roommate may have had a little issue and had some trouble getting to the bathroom. So in between your bed and the bathroom is a floor that's potentially contaminated with body fluids that did not come out of you. Now, you've walked on all of these surfaces. Now, if you really want a visual, if you go down the road to our hospital over there, there is a subway in the lobby. And if you go into the subway in the lobby, you usually will see a patient because they don't like the food there. They'd rather have Subway. And they will be there in their little hospital gown with another one thrown over like a robe, and they'll have their little slipper socks, and they're walking all over that hospital in their little slipper socks. And then they all do the same thing. They get back into bed with those slipper socks on. What do you think is now in the bed with them? Yeah, all kinds of pathogens. Now, if they've had a surgery, they have a beautiful, warm, dark, moist area for those new cooties to just cuddle right in. Yeah. You're starting to see that there might be a problem with this process. Just like gloves, a lot of times we do things with incomplete knowledge. We think we're doing the right thing, right? We wear slipper socks because we don't want to slip and fall. We did a good deed, but we don't stop to think about what's happening on the other side of that equation. We go at this with incomplete knowledge, and that is what actually puts us at way higher risk. Make sense? So slipper socks are not enough. They're not enough. If your patient is out of bed, they should have shoes on. Period. Now, a good rule of thumb to remember this is, let's go back to that 2-year-old. Love those little guys, right? Would you let a 2-year-old walk barefoot on a hospital floor?
No.
Why?
Nasty.
Okay, so there's germs, there's probably sharp objects. Okay. All right. If you wouldn't let a 2-year-old walk barefoot on a hospital floor, then why is it okay for you to allow an adult to do it? But they don't have the information that you do, right? You're starting to look at slipper socks a little bit differently. They are not the magic suit of armor you think that they are. They don't protect your patients against sharp objects at all. And we have sharp objects in healthcare. They don't protect them against pathogens. It provides a false sense of security. And they don't even do a great job at slipping. So when your patients get out of bed, if their feet hit the floor, we're going to talk about their shoes. Now, some of you are going to say, well, hold up, Miss Patty. What if they don't have shoes? What do I do then? You just said that they need shoes on, but, you know, when I was in the hospital, I didn't have shoes. What do we do then? Well, what do we do with all problems? Yeah, we take that information to the nurse, but I'll guarantee you 90% of the time your patient has shoes, they're just in a bag in the closet. You just got to go find them. But if the patient doesn't have shoes for whatever reason, then you just go to the nurse and say, hey, I got to get this patient out of bed. They don't have shoes here. Get a second set of slipper socks and put on over the first. So now we've got a thicker cushion to help protect against sharp objects. And you're going to take that second set off when you put them back into bed, like shoes. Make sense? Good. It's a temporary measure, but that nurse can solve that problem because I have this great invention called a telephone. You guys hear of that? Telephones? Yeah. So I can pick up the phone and call the family and say, hey, we need Henry's shoes. Can you bring me a pair of Henry's shoes? Or if Henry came from a facility, I'll call the facility up and say, hey, I need Henry's shoes. You didn't send him shoes. He needs some shoes. Or if they're homeless and they have no shoes, I can call the social worker and say, hey, I got a homeless patient here that has no shoes. And you know what? I can't discharge him until he does. So I have to solve that problem anyway. I'd rather solve it early so that when discharge day comes, I don't have to scramble. Good? Make sense? So look for shoes. If you walk a patient without shoes, you are putting yourself at risk. That's a liability issue. Okay? Good? Because I guarantee you, every policy and procedure manual out there has shoes on the patient. All right. So we looked for the test. If you go back to the care plan, it says they're already sitting in a chair with shoes on. Awesome. We don't have to get down there to do it. So we've got shoes on, patient sitting in a chair. I'm ready to start lifting them up, but I don't want to just grab them by the back of the arms to lift them because that's just lifting the top part of their body, and most of our weight is down here. So if I'm grabbing up here and pulling, I got to use more force, and that's going to hurt the patient. It's going to bruise them, could tear their tissue, and it also compresses nerves. All the nerves for your hands run down the back of your arm. Do you guys know that? It's called the brachial plexus. And when you compress those areas, you can actually cause nerve damage. So don't grab somebody by the arms to lift them because it doesn't work on their center of gravity. Now, some people have figured that out. Yeah, it doesn't really work well to lift the arms. So some people have figured that out. And instead, they go at the center of the body. Perfect. Good job. Right track, wrong train. Because if you lift somebody using their pants, anybody ever have a wedgie? Because this is a monster wedgie and they move. Oh, they'll move fast. Like patients stand up like that. Like, I didn't know you could move that fast. Well, they're moving because you're hurting them. Don't use pants to lift somebody. So what we need is something at the right place around their waist, but that isn't their pants that's going to give them a wedgie. So to make this work, we're going to use something called a gait belt or a transfer belt, which is nothing more than a flat canvas belt with a buckle and a free end. We're going to put this around the patient's waist, not yours, the patient's waist. You'll see a ton of CNAs walking around with these around their waist. They're carrying them there. Not a great idea. I mean, I can't stop you from doing it, but this is going to go around the patient. You probably don't want to be putting all of that on your uniform, right? Does not matter when you put this on if the buckle is facing this way or if the buckle is facing this way. I don't care. Nobody cares. What matters is the tag is on the inside, like every other article of clothes. So when you put this on the patient, it goes around their waist. Now I'm going to put it on mine just to show you, okay? But remember, it goes around the patient's waist, not up here, waist. Jake, you're going to want to zoom in on me. I'll try to hold still. Can you guys see the TV behind me? Am I in the way? Okay. Am I good?
Very fluid movement. I apologize.
Tell me when I'm good because I can't turn around.
All right.
Okay. So we have the buckle. Like I said, doesn't matter whether the buckle faces this way or the buckle faces this way. Nobody cares. Nobody cares. But you want to take the flat belt and wrap it around the patient's waist. When you do, you don't want it twisted. You want to make sure it's flat. So I'm going to place this around the waist, making sure that it's flat. Now I'm going to take the free end and put it through the first guard by the alligator teeth. Okay, not through here. We want it through the first guard by the alligator teeth. Good. Now I'm going to pull it so that it's snug. And I want it snug. Not loose. This is way too loose because when I go to lift this, it's going to go up underneath the breasts, under the arms, or the patient will slide right out. The whole point is we want this to stay in place when we're lifting. So you want it snug. Now, how do I know it's snug enough? I take 4 fingers, slide it under the belt, between the belt and the patient. I should only be able to fit 4 fingers. If I can fit an entire fist, way too loose. 4 fingers. And once I get it snug enough, we're going to take this free end. We're going to put it through the second guard over here. And we're going to pull it tight. Now, this end hanging down might be too long because a lot of you guys are skinny people. If this end is too long, you just tuck it up into the belt to get it out of your way so it's not a tripping hazard. To remove a belt, we're going to take it out of the second guard like this. Now, the easiest way to remove a belt, when you put it on, you're pulling on the belt tail. When you take it off, you pull on the buckle, hold the belt tail stationary and pull on the buckle So to tighten it, hold the buckle, pull the belt. To loosen it, hold the belt, slide the buckle. Pull this out of that second or that guard. Now, when you're taking this off the patient, you don't want to slide it. Listen close. Can you hear this? You guys hear that? That's going to cause a friction burn. That's going to hurt your patient, especially if they have fragile skin. So we don't do that. We either bring our hands around and gather the belt, or you can loop up and over, holding on to the buckle so it doesn't hit them in the head. Okay, good. That's how we use a gait belt.
And if the patient's sitting in a chair, when you sit them down in the chair, just ask them to sit up so you can remove the gait belt.
Right, right.
Okay.
Yep. Just going to ask them to lean forward.
Okay.
All right. Thank you, Jacob. Okay, so before we lift a patient to a standing position, there's a couple things that we need to address. So our gait belt is on. We're ready to go. But before we lift, we want to make sure their feet are flat on the ground. I have a problem with this. My legs are short. Even though it looks like my feet are on the floor when I'm sitting, they're actually not flat. I'm up a little bit on my tiptoes. So if you were to try to stand me up from that position and I'm on my tiptoes, I'm going to fall forward because my equilibrium is not there. So you want me to scoot forward in the chair a little bit, move my butt forward so my feet are flat on the floor before you lift me. This is an important thing. Always make sure their feet are flat on the floor. So you can just ask, are your feet flat on the floor? I also like to make sure that their shoes are fitting well. Like, I see you have shoes on, or do you have, are your shoes tied appropriately, or do your shoes fit okay? Because if they're having an issue, if they have a blister, or if they're favoring one side, that's going to affect how I lift them. It's going to affect their equilibrium. So I like to get some information there. Good? Good? All right. Okay, so when we lift, we don't just reach around, grab them, and stand them up. They're not a lump of flesh. They are a human that needs to participate. So we're going to count to 3. I'm going to stand you on the count of 3. Ready? 1, 2, 3. And then we stand together. If I just grab the patient and start to move, they'll stiffen up. They'll resist. They'll become, because they're not real sure what their role is here and what's happening. So make them a partner by counting. That's a graded checkpoint, guys. We're going to stand at an oblique angle. Don't stand toe-to-toe, knee to knee. We used to teach people to do that. If I've got a patient sitting in front of me and I'm standing knee to knee and toe to toe and I'm lifting them, there's a physics principle here. Every action has an equal and opposite reaction. So all of their weight is coming toward me. That means my body has to offset all of that weight, which is going to happen in my lower back. I'm going to bend backwards to accommodate that weight. It'll blow your back out. Don't do that. That's bad body mechanics. Don't do that. So instead, we're going to stand in an oblique angle. And what I mean by that is if you have a patient, I'm not going to do it in this chair because this chair is a rolly chair, but if you have a patient sitting in the chair, okay? So if you have a patient sitting in the chair, instead of standing in front of the patient like this, I'm going to stand at the corner of the chair. I'm going to put one foot in front of their feet across, perpendicular, so their feet can't slide out. The other foot goes parallel to the chair. I'm standing at the corner of the box, one foot on each side. I'm going to bend at the knees, not the back. Okay, we don't bend at the waist. We don't stick our butts out. We go down like this. I'm going to grab the back of the gait belt and have them put their hands on my shoulders. I'll tell you that. You'll see that there. And on the count of 3, we're going to stand 1, 2, 3. And when I stand, I step back. This keeps me out of that equilibrium force. Keeps me more steady. Good? Questions? Okay. Once we get them standing, you want to ask if they're dizzy. I want to know here, not over there. If we get over there and I finally say, hey, are you dizzy? And they go, yes. Well, what's my exit strategy? Yeah, good luck. I don't know. What am I going to do? Right, I want to know here. So I'm going to stand them up. Are you dizzy? Yes, sit down. We're not going nowhere. I'm going to go find a nurse. They solve problems. I don't. Got it? But let's talk about getting over there. So we stand the patient up. They say that they're not dizzy. We stand them up. We go for a walk. We get way over there. And I see something's going wrong. And you can always tell that they get pale or sweaty. They start to wobble a little bit. And I can pick that up because I'm holding the gait belt and I can feel the wobble. They might put their hand out to the wall because they're unsteady. Sometimes they'll put their hand up here or here. But there are signs everywhere that something is about to go very wrong. Your patients don't just walk along, I'm fine, I'm fine, I'm fine. Ugh. It doesn't happen that way. There are signs. If you're not picking them up, that's a you problem. Good? So as we're walking, if I start to see signs, what do I do?
Find a chair.
All right, that's what everybody wants to do, right? Rush them back to the room, find a chair, get them back to safety. Sounds reasonable, but your patient isn't tolerating a slow walk. What makes you think they're going to tolerate a rush?
You can either sit them on the walker or slowly place them on.
Ah, there it is, right. So if you've got a walker with a seat, that's great, but if you don't, let's get them on the floor because a patient that's sitting on the floor can't fall on the floor. So we do that in a couple of ways. You can back them up against the wall and help them slide down the wall. Or because of the way that I'm walking the patient, I am going to be slightly behind them and off to one side. So my patient is here. My gait belt is being held by this hand. So this patient right here is my full attention. I'm not looking at my phone. I'm not talking to other caregivers. This person is 100% on my radar because I'm looking for signs. And if I get one, as we're walking with me in this position, this leg goes right there, right in between theirs. This arm grabs the gait belt and I pull them against me. Do you see the stability of my position? Now they're leaning against me. All right, Henry, we're going to the floor. Just slide right down my leg. 1, 2, 3, and we're on the floor. I don't need a wall. I don't need a walker, and I can get them on the floor that quick. And now they're not breaking hips. I've got soap to wash off whatever they come into contact with on the floor. I do not have soap that can wash off a broken hip. Good? Makes sense? You will have a written test question. And almost everybody answers, rush them back to the chair. They're not going to make it. They're not going to make it. Okay? Good? Good? All right. So once we get them back to the chair, we've taken our walk. And remember, the care plan told us 10 steps. That's 5 steps in one direction and 5 steps back. This is not a long walk. Not a long walk. So we're going to get them back to the chair. But once we get them back to the chair, you can't just have them sit down because if they're here, they have no idea if there's anything behind them. Right? If I just if I just bring them over here, they've got to back up until they can feel that chair behind their legs before you ask them to sit. You're helping them sit, yes, but you don't deserve that kind of trust. Okay? You don't deserve that kind of trust. Here. Ready?
I don't even know how that happened.
I know, it just like, it jumped off.
Right?
Nobody was near it. It was weird.
It was weird.
Yeah, it's weird. All right, so we're going to ask them to back up so they can feel that chair behind them. We're going to use that same body mechanics, 1 foot in front of their feet, 1 foot beside the chair to lower them into the chair. Their hands need to be on your shoulders. This helps them move as a unit. If you just have their arms at their sides, what's going to happen? Because you're pulling here, right? That gets them off balance like this. And that can actually contribute to a fall. When you have, just leave it right there on the floor. When you have their hands on your shoulders, just laying there, not around your neck, not grabbing anything, just laying there, it moves their whole body as a unit. Their arms aren't trailing behind. In your book, let me borrow your book real quick. I'm going to go back. Go back to page 61. Oh, I don't know why I did that. Sorry. Go back to page 61. At the top of the second column on page 61, you can see a picture that shows you if somebody's arms are at their side, the posture that happens when somebody is lifting you. You guys see how they're tilted backward? That's a fall risk. I actually took that screenshot off of a video that is on YouTube for this skill to show you, because it was a very good visual representation of why this is a fall risk. Good? Good. Oh yeah, guys, don't trust that everything you see on YouTube. You guys can all start. You do know there is no approval process, right? You guys can all start YouTube channels, right? You can say anything you want. I could start a YouTube channel to convince you that the sky is actually purple and you've been lied to all your life. And nobody will stop me. So understand that what you watch and the resources you use may not be test accurate. There is no approval process. So use discretion. All right, so here are our shoe rules. If the patient's feet hit the floor, we talk about their shoes. Slipper socks are never enough. They have to have shoes on. We're going to put the gait belt on and make sure we check it with 4 fingers to make sure it's tight enough. Their feet have to be flat on the floor before we stand them, and we're going to count to 3 before we stand. After we walk, when we return to the chair, they've got to feel it against the back of their knees before we help them sit.
Patty, should we rock them?
No, we don't rock.
Okay.
The only reason an older person rocks is because they lack strength.
Right.
Right, they have to get momentum. We're giving them our strength. They don't need to rock. Okay? Good? Good. All right, there's one more step for the state exam that I want to talk to you about. Some of the evaluators are doing this. They're not supposed to. But we do have some rogue evaluators out there. So I need to bring this to your attention. The last couple of classes said that nobody did this, so that's good. Hopefully they've kind of got to the bottom, but I still want you to be aware of this. There are a few evaluators that will put this table in your walkway. So when you go to take the test, you read the care plan, it says walk them 10 steps, but they're actually going to give you a destination. They're going to say walk to the table and back, or walk to the door and back. They give you a destination that's about 5 steps roughly. So you're walking the patient, but before you start the skill, they will move this table in your path. They'll literally put it right in the middle because they want to see what you're going to do. You cannot leave your patient once you're walking them, and you can't move something out of their path when they're supposed to be your whole focus. Do you see how that's a problem? So when you're going to do this skill, it is a very good idea to get in the habit of looking at your pathway and removing any obstacles before you stand the patient up. Now, this isn't a graded checkpoint, which is, remember I said that the evaluators have to abide by rules too? It's not a graded checkpoint, which means the evaluator should never add this in as an additional level of complexity. It's not their role. And it actually removes the uniformity from the test. They're not supposed to do that. But they're human. And sometimes humans do things they're not supposed to do. So look and see, is there anything? They're going to give you a destination. Just look. There's nothing in my pathway. I'm good. Okay? Go ahead.
I don't want to overcomplicate it. Might go over it. I don't know, but so you're walking them in the process of the 5 steps. Sorry, you're walking them 5 steps and you're doing it backwards.
Yeah.
Are they walking backwards, or are you actually?
Oh, you're turning. Yeah, no. Thank you. Good question. No, you walk them, you turn, and then you walk back. Yeah, good. I never thought about that. I'm going to have to do that as one of the things that I'm working on. They're not going to be done for you guys, but it's something that I am working on. Are common testing mistakes, and we actually taped like 120 of them. Things that you shouldn't do on the test. Yeah, well, it's a lot of editing. I mean, 120, there's a lot of editing. So, but I'm going to have to think about that. You know, I never thought about that one. So that's pretty cool. Doreen says, good morning, Nurse Patty. I passed my exam on the 17th of September. I've not received my license in the mail. What should I do? Well, congratulations, first of all. And Doreen, this is going to depend on the state that you're in. Most states do not give an actual paper certification that is sent to you anymore. They've done away with those. Florida also, as of this year, does not give you paper certifications. Nothing is going to be mailed to you. Everything is now electronic. So simply go to your favorite search engine, whatever search engine you like, type in FL CNA license lookup, and it'll bring you to the MQA site where you can look up your certification, print it out if you want to. But all future employers have to go directly to that website to verify your certification. Your card means nothing. So that's why they don't give it, because anybody, I've created, fake cards for this, for education purposes. And they look, I mean, other than the fact that they say fake, they look just like the real thing, right? I've got graphic art skills, and a lot of people do. So because of that, I mean, I can create a certification for you, with a certain amount of money. It doesn't mean it's valid, right? Yep. FLCNAlookup.com, or no, FLCNA license lookup, just in a Google search or a search engine. Yeah, FLCNA license lookup. So just look your license up. But you don't need it. You don't need it. Your employer has to go direct and look it up. That's their responsibility. All right. I don't know why. I don't know who is putting gait belts on under clothing during the test, but this is a testing checkpoint. Don't know why. Guys, every testing checkpoint means that a certain amount of people have done that action to make it a checkpoint. So how many people have been taken? I don't know. It's checkpoint. It's a checkpoint. You're going to hold that gait belt around the sides. Don't ever pull from the front. Don't ever pull from the front. Sides, back. This is the picture I was talking about. Make sure their hands are on your shoulders, not hanging to their sides. Gets them moving as a unit. And then we're going to let the patient lead. We're going to walk slightly behind and to one side as they walk. Once you get them standing, ask if they're dizzy. Once you get them back to the chair, lower them into the chair using that body mechanics that we talked about, making sure they can feel the chair behind them. And then we'll remove that gait belt. Make sure that they are seated properly with their hips against the back of the chair. They're not in danger of falling. And then you're going to do your closing. Questions? They give you 5 minutes to do this skill. It does not take 5 minutes. You're walking somebody literally 10 steps. Like a minute and a half, maybe. I mean, don't rush it. You got plenty of time. Let me go ahead and show you this skill, and then we're going to get into partial bed bath, which is the longest skill. All right. Yeah. Good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Do you feel like going for a little walk?
Yes, that'd be lovely.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to clear the walkway of obstructions. We'll close the privacy curtain and wash my hands. Now that I have clean hands, I'll get the gait belt. Mr. Jones, I see you have non-skid footwear on. Does it fit appropriately?
Yes.
Very good. This gait belt I'm going to put around your waist. It's going to help me lift you to a standing position and provide a little stability as we walk. Is that okay?
Yes.
Okay, I'm just going to slide this around your back. Okay, and lift your arms and relax. We're going to put the free end through the first guard by the alligator teeth and pull it so that it tightens the belt. We want the belt to be snug. We want to only be able to fit 4 fingers between the belt and the patient, and then we'll lock it in place by putting the free end through the second guard. And then we'll place the free end through the top just to hold it in place. Okay, Mr. Jones, your feet are together. In just a few moments, I'm going to have you place your hands on my shoulders, and I'm going to place my hands around your back. And on the count of 3, we're going to stand together. Okay?
Okay.
So I'll put 1 foot in front of your feet to keep them from sliding out, 1 foot beside the chair to keep me at an oblique angle. Go ahead and put your hands up here. And on the count of 3, we're going to stand. 1, 2, 3. Thank you very much. Are you dizzy at all?
No.
Okay. So at your pace, when you're ready, I'm going to have you lead and we're going to walk to the wall. I'll walk slightly behind and to one side, watching the patient. Okay, and go ahead and turn. And then we're going to walk back to the chair. Are you dizzy at all?
No.
Very good. So when you get to the chair, if you can turn around for me and back up so that your knees hit the chair, come my way just a little bit. And on the count of 3, can you feel the chair behind you?
Yes.
You're going to place your hands on my shoulders. Go ahead. I'm going to put 1 foot in front and 1 foot beside. And on the count of 3, we're going to lower. Ready?
Yes.
1, 2, 3. Being careful to bend at the knees and not the back. I'll remove the gait belt by taking it out of the second guard and then removing it from the first guard. We're going to remove it by looping it over the patient, being careful not to let any part hit the patient. And are you comfortable?
Yes.
Could you slide back so that your hips are against the back of the chair? Very good. I'm just going to go put the gait belt away. Are you comfortable, Mr. Jones?
Yes, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your environment is clean. I'm going to hand you your call light. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections that need to be made, and then tell the evaluator my skill is done. Okay, any questions?
I do.
Yes.
A small one. When you're fitting the gait belt,
Mhm.
4 fingers this way or just like this?
Flat against their body. Yeah. Good. All right. Moving on. Partial bed bath. This is the longest skill we do. If you look at this page on page 126 and you look down here, the test is giving you 19 minutes for this one skill. It's a long skill. But the good news is, if you get this one, you get respirations, super short, and you get range of motion, super short to go with it. Okay. So it's a long skill, but it's offset by 2 super short skills as its buddies. Oh. So during the test, you are going to be given a care plan, right? One of those. And they're going to tell you you have 31 minutes to do this care plan set, all 3 skills. So you've got 31 minutes. Now, at 26 minutes, they're going to give you a 5-minute warning. They're going to say, you have 5 minutes left. Now, what you want to do is get as many checkpoints in as you can during that 5 minutes, because it's not an automatic fail if you go over time. Not an automatic fail. You're just not going to get credit for anything you didn't do. Remember all those checkpoints that we need? And remember that most of our checkpoints come from our opening and our closing. So if you get a 5-minute warning, you need to get to your closing as quickly as possible. Get that closing done so you can get those checkpoints. My students generally don't time out. I haven't had a student time out and I can't even remember how long. It's been a long time. Primarily because you guys know, you've got a vague idea of what to do. You're not restarting the skills over and over and over and over and over again. That really annoys the evaluators. Where do they want to be? At home. Yeah. And if you're doing mouth care, if you're doing mouth care and you're starting it 8 times because you can't remember your opening and you keep forgetting supplies and you're like, just let me start over. I got to start from the top because you keep doing that. They're rolling their eyes and they're like, pool, right? And you'll really irritate them. My students don't do that, because you have a defined starting point, right? Every skill starts with the opening. Every opening starts with a knock. I mean, you know where to start. So my students don't generally time out. You've got a pretty good understanding of how this whole thing is supposed to go. It's not just a whole bunch of random steps that don't mean anything. Okay. Make sense? Yeah, you guys will be fine on time. But this is a long skill. Even when I do it, it's a long skill. So let's get into it. You know all of the principles for this skill. You know every one of them. We know to read the care plan and do what it says. We know that every skill starts with an opening. We know that we're going to need gloves because of wet body openings here. We know that we need a barrier to put our supplies on. We know our patient's going to be uncovered and undressed, so we're going to use a privacy blanket. We know not to let our uniforms or our supplies touch our uniform and nothing goes on the floor. We know that the patient must always be in the middle of the bed. We know if we're going to get water, we're checking it and they're checking it. Whatever we wash, we rinse. Whatever we rinse, we dry. We know that we're going to clean the basin the same way. We clean every basin. And we know the end of every skill, we have to do our closing. We know all of that. There is nothing there that you need to learn. Nothing. You have the information you need to do this skill already. Just by following that, you guys could figure out how to wash a body. Whatever the care plan is what the care plan tells you to wash, you could wash using that. But we are going to learn a brand new technique for washing. This is the very last thing that we have to learn on principles. So if you look at the care plan at the top of page 127, our care plan tells us to give the resident a partial bed bath. Let's stop there for a second. Time out. What does the word partial mean? Part of. Yeah. Yeah, part of. Not complete, right? So if there's a whole body there, we're not washing the whole thing. We're going to wash part of it, but part of it isn't specific. If a care plan is a partial bed bath, it's got to tell you what parts we're supposed to be washing. So the rest of this care plan, super important. If it just said give the resident a bed bath, that would be easy because whatever's there, you're going to wash. What you see is what you get. But this says partial, so we got to pay attention. It tells us to wash, give a partial bed bath and back rub. We're not massage therapists. There's no deep tissue anything. It's just a quick circulation inducing, make them feel better thing. All right, it tells us to wash the resident's face, neck, chest, back, and one arm and hand. How many arms?
One.
What if they have two?
Just do one.
Just do one. And the test is going to let you figure out which one you want to wash. They're going to leave it wide open for you. You pick. But in a clinical setting, if the care plan says one arm, there's a reason we're not doing the other one. So it's going to tell you which arm. Pay attention. Okay? They don't do that just for giggles. They don't just say, yeah, just do one arm. That's weird. You would only do one arm because the other one has a cast. Or the other one's been amputated. Or the other one has shingles, which is a weepy infection that's got goo everywhere. Right? So we would want you to avoid that arm. Good? All right. It also tells us to use soap and water. So what are we using?
Some water.
Okay. Provide a brief back rub with lotion. Dress the resident in a clean hospital gown after bathing. Patient is lying on back in center of bed and can roll as directed, but is too weak to assist with bathing. So we can ask him to scoot toward us. Okay. Now go back a page. Who are we doing this on? A live person? A mannequin. Yeah, page 126 at the bottom will tell you that. So even though the care plan says that they can roll as directed, she's not really going to cooperate. She's not really going to roll. You're going to have to help her out a little bit. Now, she is a Barbie. She is a big Barbie. Barbie dolls, if you have any experience with them, do not lay on their sides very well. They will always flop back. So during this skill, when you turn the mannequin over on their side to wash her back, the evaluator will just walk over and hold the mannequin in place. They know mannequins don't stay on their sides. If the evaluator is off in dreamland somewhere and just kind of missed that cue, you can ask him, hey, can you come hold this mannequin because she does not stay on her side. Real people do. You don't need somebody. Real people stay on their side just fine. She's not a real people. Don't tell her that. You might offend her. Supplies are at the bottom. A lot of supplies. You need to learn them. Flashcards are your friend. All right, so here is our last principle. This is it. Drum roll. This is the one thing that we have not learned yet on washing rules, and that is that we are going to use the leaves method for wet body openings. So what is the leaves method? Well, before I tell you that, let's review the rest of washing rules. Remember that basins are no soap zones. We do not add soap to the basin. That keeps our water clean for rinsing. Oops, hold on. We're going to use a paper towel to turn the faucet on, and we're going to make sure it's warm, not hot, not cold, just warm, using the inside of our wrist. We're also going to ask our patient to check the water. We know all of this. Whatever we wash, we rinse. Whatever we rinse, we dry. We're going to change the water if it gets cold or soapy, and we're going to try real hard not to get our surface wet. But in this situation, we're washing the patient in bed. So our surface is not just the table, although that's important. It's also the bed. So when we're doing this skill, we're going to put a towel on the bed underneath the patient to catch any water that might roll off the patient. But the goal here is to get your washcloths wrung out so well they're not drippy. Good? Good? All right. And then we're going to give them a back rub with lotion. So we'll warm the lotion up in our hands and then wipe off the excess after. So this is the one thing that we haven't learned yet using the leaves method. So let's learn that. So you all have a washcloth in front of you. This is just a plain washcloth. We have these at home, probably in our linen closet somewhere. They're usually folded in half and then in half again into a square. Everybody familiar with that? Instead of looking at it as a square, I want you to look at it as a diamond. And specifically, there's a way this diamond has to face. Do you see this part where it's like free corners? You know, the free corners, not folded corners. See how this one has folded corners? This one is folded. This one is folded, but this one has the corners that are free. We want the free corners up, free corners at the top. So we have our square that we turn into a diamond with our free corners at the top. And we're going to put this on our hand like this with the free corners up. When you do that, you're going to tuck in one of the corners between your pinky and your ring finger. So hand, washcloth, tuck in. This one gets tucked between the thumb and the index finger. So you should have this in your hand. Good? Okay. We are going to use this method anytime we're going to wash wet body openings. We went over this in class 2. You guys remember wet body openings? Portals of exit, portals of entry. So the eyes, the nose, the mouth, the genitals, the rectal area, wounds, rashes, sores, and incisions. If we're going to wash any of these, we need a special way of washing so we're not cross-contaminating. So if we have this washcloth in our hand, right? So in our hand, fold, tuck. Now we've got an area to wash with. We can wash a wet body opening. So let's say I'm going to work on the face. Inner to outer corner on the eye. Now I've got cooties. So I'm going to fold that leaf over, and that tucks the cooties underneath. Now I've got a clean area of the washcloth. So I can wipe the other eye, and I can fold that down. And I've got a clean area to work with. Then I can wash the skin of the face, and I can fold that down, giving me a clean area to work with. And then I can wash the nose. Nose last, boogers. Okay. And I can fold that down. And if I needed another leaf, I could use the back side. So this one washcloth gives me 5 independent cleaning surfaces without cross-contamination. So eye, fold it over. Other eye, fold it over. Skin and mouth, fold it over. Nose, fold it over. And I could use the back one if I needed to.
What about the neck and the chest and the back?
Okay. There's no wet body openings here, right? So we use the leaves method when we're washing wet body openings to prevent cross-contamination. If the skin is intact, you don't need the leaves method. You just use a washcloth. Okay? Do you guys understand leaves? All right, so let's look at this care plan real quick. It says, give a resident partial bed, bath, and back rub. Wash the resident's face, neck, chest, abdomen, back, one arm and hand with soap and water. Provide a brief back rub with lotion. Dress the resident in a hospital gown. Patients lying on back and center of bed and can roll as directed. All right, so that's our care plan. So we're going to start with the face. No soap on the face. Soap dries the skin, stings the eyes. No soap on the face. So just a water washcloth. I'm going to take my washcloth, wring it out really well, hold it in a diamond shape, tuck in my 2 side corners, and no soap. I'm going to wash one eye, fold it over. The other eye, always from inner to outer, fold it over. I'm going to wash the skin on the face and the mouth, fold that over, and then the nose last. And I'm going to set that on my barrier on the table. It's got boogers on it. I don't want to use it anywhere else. And then I'm going to dry those areas because whatever we rinse, we dry. Remember, no soap. So it was rinsing. Whatever I rinse, I dry. We're going to use the leaves method on wet body openings. I want to make sure I'm wringing those washcloths out really, really well. There should be no drippy wet washcloths. If during the test you look at that sheet and you see water drops on the sheet, that evaluator saw water drops on the sheet. Are you going to ignore that? Because in a clinical setting, yeah, that's somebody is in a wet bed. That's not cool. So if you see that the bed is wet, the sheet got wet, you would say during the test, I would change that sheet. They're not going to make you change it, but you do need to recognize it. Okay. All right. We're going to wash. So we used one washcloth. We washed the face, set it aside. We got our second washcloth and wrung it out really well and applied soap. Now this is just normal skin. So you just have to apply soap to the top and you're going to wash the neck, under the chin, down to the chest, the abdomen, and one arm and hand. But when we lift the arm, just like we did with range of motion, you want to support that arm as you lift it. Whatever you wash, you rinse. So we'll use washcloth 3 to rinse, and whatever you rinse, you dry. So we've done the whole front of the patient. Face with the leaves, the rest of it with just a soapy washcloth, rinse it and dry it. Now that rinsing washcloth, we can reuse because we didn't put soap on it. So for the test, if you want to use 5 washcloths, you can. 5? No, 6. Sorry, 6. You can, no problem. Go ahead. But I'm going to show you how to do it with fewer washcloths because in most settings, you don't have enough supplies. In a lot of nursing homes and assisted living facilities, when you go on shift, you're going to get report. You're going home for the day. I'm relieving you. I'm going to find out about my patients. As soon as report is done, we all know there aren't enough supplies to get through the shift. We know that. So I'm going to run to my supply closet and I'm going to take all of the supplies I think I'm going to need and I'm going to go hide them. So you come along, right? You finally got out of your report. You go into the supply closet and there's 3 washcloths left. And you got 12 patients. Now, I wish I could tell you this didn't happen. Anybody work in healthcare? Tell me I'm lying. Don't do that, guys. Don't shortchange your other staff members, okay? Don't do that. But you have to know how to do these skills with very few supplies because that's going to be your reality. So I'm going to show you how to do this. Any rinsing washcloth can always be reused to apply soap to for the next body section. Anything with soap on it cannot be put back in the basin. Anything with cooties, wet body openings, cannot be reused. But if it's just a simple rinsing washcloth, you can reuse it, no problem. Good? All right. So when we're done with the washcloths, we're going to put them on our barrier. When you have a barrier, make sure you have a clean area and a dirty area in your mind, just so you're not, mixing the two up. Once we get the front done, we're going to scoot the patient toward us, turn them on their side, evaluator will hold the patient, and you're going to wash the front or the back, rinse the back, and dry the back. Once you're done washing, rinsing, and drying the back, we're going to get a little lotion, warm it up in our hands, and we're going to go from the base of the back, the small of the back, up to the shoulders in small circles, and we'll do that 3 times. Up, and done. We put lotion on, so we're going to wipe off the excess with the towel that was under the patient protecting the bed. Now's a good time to take it away and wipe it off. Now, our care plan also told us that we needed to change the patient's gown. Clean body needs a clean gown. That makes sense. When you do that, nobody cares. Nobody cares. Nobody cares. You want to wait till you get the whole body clean and then go back and take the old gown off, put the new one on, that's fine. Go ahead. But it's going to take longer because now you got to flip the patient over again to tie that gown. So smarter, quicker is when you get the front clean, put the gown on. Turn them on their side, wash, rinse, dry the back, give them the back rub, and all you got to do is tie that gown. That's the way I'm going to show you in the video. That's the way it is in your book. You can do it another way. It's fine. But this is the quickest. So let me give you guys, because we're nearing the end of the program now, and you're starting to think about work. So I want to give you some very helpful hints about what it's like to work in a healthcare workplace. Let's say that you have 10 patients to care for. 10 patients to care for. And you're working a 12-hour shift. Now, in that 12-hour shift, you're going to get a 30-minute break. Meal break. 12 hours is a long time. You got to eat. So 30 minutes. You got 10 patients. Now, it's probably going to take you about 5 to 6 hours to get to your break. So on these 10 patients for 5 hours, the first 5 hours of your shift, if you spend an extra 15 seconds, an extra 30 seconds, an extra minute, we'll give you 15 seconds, 30 seconds, and minute, 15 seconds, 30 seconds, and minute, you're going to take an extra 3 minutes. You're going to take an extra 2 minutes. You're going to take an extra 4 minutes. My break is gone. I don't have time for my break now. And it happened in 15, 20, 30-second snippets. But over a 12-hour shift, that extra 15 and 20 and 30 seconds adds up. And the only place you have to cut is your break. Do you see how that can be a problem? So you really want to make sure when you get into healthcare that you are efficient, that you learn how to guard your time. And that's why I give you all of these little time savers along the way. Okay. Make sense? Okay. All right. All right. So the best way to do this is to clean the front, change the gown, turn them over, clean the back, give them a back rub, tie the gown. It's going to save you some time. So I'm going to skip all this. So we don't need these. Okay. So after you're done cleaning the patient, you're going to take all of your soiled items and put them into the dirty linen hamper, clean your environment, and then do your closing. You also have a privacy blanket on the patient during this skill. Now, you had gloves on because you cleaned her face and there's body openings there. So you had gloves on. You need your gloves to put all of that stuff away. You got cooties on those washcloths. You need your gloves on for that. But we also have to take the privacy blanket off at some point. Do we want to touch this sheet that's going to go right up next to her face with soiled gloves? So we have to remember that we're going to put all of our dirty items in soiled linen. We're going to clean our basin and put it away with our paper towels. Then we're going to take our gloves off and take the privacy blanket away and put it in dirty linen as well. The order there matters. Good? Good. Any questions? All right. So we're going to remove our gloves and then remove our privacy blanket and then do our closing. All right. So let me show you this skill. This video takes about 12 minutes. It's a longer video, but it doesn't take 19. Yeah. Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I'd like to provide a partial bed bath. Is that okay? Wonderful. I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I've washed my hands, I can gather my supplies. I'm going to place the supplies on the overbed table. We'll start with a barrier, unfolding the barrier so the absorbent side is facing up, and this gives us a clean place to put our clean supplies. For this skill, we're going to need 2 towels, 4 washcloths, 1, 2, 3, and 4. I need a privacy blanket and a clean gown. Being careful not to hold the clothing against your uniform. I'll bring this over to the patient area. We'll bring this over here within reach, and then I'm going to get the supplies out of the drawer that I need. We're going to open the middle drawer and remove the basin, soap, and lotion. I'll put these on the overbed table. And I'm going to get a set of gloves. Okay, Miss Jones, I'm just going to get some water in the basin. I'll be right back. I'll use a paper towel to turn the faucet on. Check the water temperature with the inside of my wrist. It should feel warm, not hot, not cold. And we'll fill the basin about 1/4 of the way full. Okay, Miss Jones, I have the supplies here. Would you like to check the water temperature and make sure it's okay? It's good? Very good. Okay. So I'll put the washcloths in the water. And the first thing that we're going to do is place a privacy blanket over you. This is going to help keep you warm and provide privacy while we do this skill. We're going to spread this out without snapping it or shaking it. Placing it over the sheet. And I'm going to pull your sheet down to just below your waist. Okay, now I'm going to put the towel on the bed. This is going to help keep your sheets dry, and we'll untie your gown. So I'm going to help you sit up by putting my hand on your upper back, and on the count of 3, we're going to sit. 1, 2, 3. Very good. I'm going to untie your gown. And then we'll spread that towel out underneath the areas that we're going to wash. Come on back. Very good. And I'm going to remove the gown on the side closest to me, supporting at the elbow as I lift. Okay, Miss Jones, go ahead and bend your elbow. Thank you. And then we'll move the gown over to the other side, making sure that you're covered at all times. Now we're ready to start washing, so I'll go ahead and put my gloves on. We'll take the first washcloth, wring it out really well, and then I'm going to hold the washcloth in my hand so the free leaves are at my fingertips and tuck in the 2 side corners. And this allows us to use a different leaf for each area that we're going to clean on the face. After wringing out the washcloth, no drippy wet washcloths, we're going to wash your face first. I'll start with your closest eye, and we're going to wash inner to outer corner using the leaves method, which is going to help prevent cross-contamination. So with the first leaf, we're going to wash the inner to outer corner of this eye. We'll fold that leaf over. And with the second leaf, we'll wash the inner to outer corner of that eye. fold that leaf over, and with the third leaf, we'll wash the remaining skin of the face. We'll fold that leaf over, and with the last leaf, we'll wash the nose. And we're going to put this on the barrier. Whatever we rinse, we dry. So I'm going to take the towel and fold it around my hand so I have control over it, and I'm going to pat all of those areas dry using short, soft strokes or a patting motion. We'll set the towel aside. Okay, now we're going to take washcloth number 2 and wring it out really well so that it's not drippy wet. And then we'll apply soap to the top leaf. We're going to start cleaning the neck, behind the ears, under the chin, across the neck, the upper torso, down to the breast, keeping the patient covered at all times to protect modesty, down to the belly button, and up the side. Now, for the test, you will keep the patient covered. The evaluation. So under the chin, behind the ears, across the neck, the upper chest, around the breasts. When you lift the breasts, we lift not with the palm, but with the back of our hand to lift the breasts to clean underneath, down to the belly button, up the side, down the front of the arm, all the way to the hand, supporting the elbow at all times, either with your hand or the bed, up the back of the arm, and we'll clean the armpit last. We're going to set that on the barrier. Whatever we wash, we rinse. So I'm going to get a rinsing washcloth, and we're going to rinse all of those areas the same way. So behind the ears, under the chin, across the neck, upper torso, around the breasts, down to the belly button, up the side, down the shoulder and the front of the arm, supporting the elbow, the hand, lifting the arm from below, washing the underside of the arm and the armpit last. We'll set that washcloth back in the basin for future use. We're going to take the towel, controlling the edges, and we're going to pat all of those areas dry or use short, soft strokes. Nothing vigorous. So the abdomen, down the arm, lift the arm up, support at the elbow, dry the hand, lift the arm to dry the underside of the arm and the armpit. We'll set this aside. Now, the care plan only asked us to clean one arm. So we don't have to go over and clean the other arm. And that's because that's what the care plan instructed. In some cases, you will have to clean both arms. In that case, you would just do that at this time. But for right now, we only had to clean one arm. We did that, so we're going to dress the resident in her gown. I'm going to spread the gown out, put my hand in through backwards on the armhole, lift her hand by holding her fingers together to place the sleeve over the arm, and then I'll lift at the elbow to bring the gown up. I'm going to make sure that gown is covering her. Put the privacy blanket back in place, and now I'll go to the other side of the bed to remove the old gown and put the new one on. Okay, now I'm going to move the blanket and remove the gown from this arm by sliding it off the arm, lifting the elbow from below with a flat palm, and then this will go in dirty linen. Now I can put the new gown on this arm by putting my hand in through the armhole backwards, grasping her hand, and sliding the gown over. We're going to lift from below at the elbow and make sure that the gown is properly in place. Now I'm going to go back to the other side of the bed. Okay, Miss Jones, I'm going to wash your back now. So I'm going to pull you toward me and turn you up on your side, and that way you're in the middle of the bed after the turn. Okay, go ahead and slide toward me. And then you're going to roll on your side. 1, 2, 3. Thank you very much. The evaluator will hold the mannequin in place during your cleaning, during the test. Live patients, of course, can lay on their side. So I'm going to ask the evaluator to please hold the mannequin in place for me. Thank you. We'll slide this towel down so it's covering the bed underneath the back. We're going to take our third washcloth, wring it out really well, and we'll apply soap to the top leaf. I'm going to wash the back from the neck down to the shoulders, all the way down to the waist. We'll set this washcloth aside, and we'll get our rinsing washcloth. So we'll wring that out, and we'll rinse the same way we washed. The back of the neck, the shoulders, all the way down to the waist. We'll set that aside, and we'll take our towel to dry those areas. So I'm going to pat dry or use short, soft strokes and dry all of those areas. Now the care plan asks me to provide a brief back rub. So I'm going to take my lotion, put a little bit in my hands, and then I'm going to warm it up by rubbing my hands together. We're going to start at the base of the back and go up in small circles to the shoulders, and we'll do this 3 times. To the shoulders, come down, up to the shoulders and come down. And then we'll take the towel and wipe off the excess lotion. We'll remove that towel from the bed, putting it on the overbed table, and then we'll tie the gown. Come on back, Miss Jones, onto your back, and then scoot to the middle. Thank you. Okay, you're covered and safely in the middle of the bed. Let me go dispose of all of my supplies, and I'll be right back. So I'm going to put all of the supplies in dirty linen, being careful not to hold them against my uniform. And now I'm going to clean my basin, and we'll dispose of the water in the sink. Rinse the basin, and then dispose of the rinsed water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. Okay, on the way, I'll place the lotion and the soap into the basin using a paper towel. And then I will use the paper towel to open the middle drawer and slide the basin with the soap and lotion into the drawer. We'll close the drawer with a paper towel and then throw them away. I'm going to remove the barrier, throw it away, and then I can remove my gloves. Okay, Ms. Jones, I'm going to move your privacy blanket now. So as I pull the blanket up, I'll restore the sheet. This preserves modesty and keeps the patient warm. We'll roll the privacy blanket up in a ball so that trailing edges don't contaminate other surfaces. Okay, I'm going to place this in dirty linen. We'll return the table to storage. Adjust the sheet for neatness and appearance. Okay, Miss Jones, are you comfortable? Is there anything else I can get for you while I'm here? Okay, let me place the call light in your hand. So there you go. The call light is in your hand. If you need anything at all, please press that red button. We'll be happy to come help you. Bed is in the low position. The environment is clean. I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan to make sure that everything in the care plan was addressed with this skill. I'll think about my skill and make any corrections that need to be made. And once I'm happy, I'll tell the evaluator my skill is done. All right, questions?
When you're tying the gown, I imagine it's pretty important where the knot goes and how to tie it.
Just a shoelace bow is all you need. Just a regular bow. And it really doesn't, just make sure you don't strangle them, but the gown is so big on the mannequin, it's not really going to be an issue.
Are we going to talk when we're taking the exam? Are we going to talk like you do?
You don't have to say everything I say. That's not a graded checkpoint. Okay. But you should. And there's a couple of different reasons. The first is it's going to remind you of what you're doing, what your next step is. Just that verbal repetition will help. The second is that if the evaluator is looking down at the checklist and they hear you say something that they miss seeing, you'll get credit for it. But the third reason is your patient doesn't know what you're doing, where you're headed next, can you imagine laying in bed and being touched by a wet washcloth when you're not expecting it? It's so keeping your patient informed becomes very important. Okay, good. We're going to backtrack a little bit because on class 3, I wasn't able to get to range of motion, elbow, and wrist. So I'm going to pull that into today's lesson. It's going to take me 3 minutes, literally. So if you go in your books to page 78, I don't have visuals because we're backtracking, okay? So if you go in your book to page 78, this is our overview of this skill. There's no principles to learn. Of course, we've learned all the principles now, so there's never any new principles to learn from this point forward. None. But we're going to read the care plan and follow it. We're going to do our opening. We'll evaluate if we need gloves. We're going to talk about skills specific in a minute, and we're going to do the closing. Do you guys remember the range of motion that we learned last week for shoulder? And the one we learned today for hip, knee, and ankle? All the same rules apply. So if you look on page 79, at the top of the page is our care plan. It tells us to provide the following range of motion exercises to the residents. Is it right or left? Right, elbow, and wrist, flexion, extension. That's it. Perform 3 repetitions of these exercises. The resident's not able to assist with the exercises. So we're working on the right elbow and wrist. Flexion, extension. So the right elbow goes up and down 3 times because that's what our care plan said. And the right wrist goes up and down 3 times because that's what our care plan said. Put an opening in front and a closing behind. That's the whole skill. That's it. That's it. Nothing exciting here. You do want to watch for any signs of pain or discomfort. Move slow. Always return to the start position for a full range of motion. I'm going to show you the video of this. And then there's one more thing I want to talk to you guys about before we leave today. I'm moving a few things around because we still have to get to blood pressure and my time is compressing here. So we're going to watch the video for range of motion and I'm going to talk to you about intake and output today. We're actually going to learn feeding on Wednesday, but this lesson goes with feeding. So I want to get the lesson out of the way so that on Wednesday we can just get into the feeding part. And that will leave us some time at the end of Wednesday's class to get to blood pressure. Good? Good. All right. So Jake, we're going to range of motion, elbow and wrist. This is literally a 2-minute video. Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to do some exercises on your right elbow and wrist. Is that okay?
Yes.
Let me close your privacy curtain. I'm going to go wash my hands, get my supplies. I'll be right back. Okay, now that I've washed my hands, I'm going to have you extend your arm out, palm up. I'm going to do all the exercises. All you have to do is let me know if there's any pain or discomfort. I'm going to bend your wrist up towards your shoulder like you're making a muscle, and we'll do this 3 times. So all the way up and all the way back to start. Up and all the way back to start. Feel okay?
Yes.
One more. Up and all the way back to start, making sure the elbow is on the bed. Now we're going to move on to the wrist. We're going to move the hand up and down like you're revving a motorcycle, so light fist. You'll feel a little stretch. Let me know if there's any pain. We're going to go forward and back. Feel okay?
Yes.
Again, forward and back. Still good?
Yes.
One more. Forward and back. Okay?
Yes.
Very good. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Here's the call light. If you need anything at all, press that red button. We'll be happy to come help.
All right.
Your environment is clean. Bed is in low position. We'll go ahead and open the curtain, and I'll go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions on that? I want that skill. Just putting it out there. All right, so let me get into really quickly a little bit about intake and output. So in your books, this is going to be located on page 107. We're going to talk about intake and output. So intake is everything that goes into a body. Output is everything that comes out of a body. Now, we tend to think of oral for intake, right? Things we eat and drink. And that is true. But intake can also consist of things like IV fluids, wound irrigations, parenteral nutrition, which is nutrition through some sort of a tube. So anything that goes into the body has to be counted when your patient is on I's and O's. You will count some of it, and the nurse will count some of it. Together, it will be totaled into intake and output. If your patient is on intake and output, that means that you're responsible for logging everything they eat and drink. Output is what comes out of the body. We think of urine and feces, and that is correct. But there are other types of output. There's wound drainage. There's colostomy bags. There's chest tubes and other drainage tubes. There's emesis or vomit, right? There's a lot of things that can come out of the body beyond the traditional urine and feces. So we will be responsible for logging all urine output. That's the domain of the CNAs. CNAs can also be asked to measure liquid feces. Okay. But for the most part, your output is going to be limited to urine, generally speaking. Everything else will be logged by the nurse. Make sense? Okay. So we need to understand that when your patient is on intake and output, we are just a part of the story. Other people are also logging things. Good. So let's talk about feeding. Feeding, when your patient is on intake and output, is a little more scientific, where you're actually going to be measuring all liquids. But for most people, we still log how much they eat, just to kind of get a gauge of when things are changing. So this isn't considered intake and output. This is just meal percentage. So I need you to understand these are two different things. Intake and output, much more scientific. Meal percentages, just a general overview. You guys understand the difference there? So meal percentage is going to be an estimation of how much the patient ate based on what they started with. So if they started with a steak, a baked potato, and some broccoli, and they ate all of it, they ate 100%. 100 is all. If you go pick the tray up and the tray looks like this still, they ate 0. They refused it. They didn't even pick at it. Everything else in the middle is a judgment call. If it looks like they ate about half, 50%. If they ate more than half but not all, 75 would do it. If they picked at it, they ate a few bites but not quite half, 25. It's a judgment call. Not 32.5%. Okay. So 0, 25, 50, 75, and 100. Those are your 5 percentage options. That's it. So if you look at the, where am I here? There we go. If you look at this is an activity. This is actually in your book. You have one like this in your book. If you look at this, this is our tray, what we started with. We had a sandwich, some broccoli, and some Jell-O. And when we went and picked the tray up, the first one is what we picked up. They had a couple of bites of the sandwich, a bite of the broccoli, a little bit of Jell-O. What would you call that? Just estimate it. All right, so not quite half, right? But they did take a couple bites, so it's not 0. So what's between 0 and 50? 25%. So let's look at the second one. What would you give them for the second one? About half. Yeah, it's roughly half. 50%. What about this one down here? 75, yeah. And what about this? Yeah, I would say 100 because I don't think broccoli stalks count, personally. It's closer to 100 than it is to 75. Remember, this is an estimation, not scientific. And this is just to kind of give us an idea, something to go on. If we have a patient that's eating 100%, 100%, 100, 100, 100, 75, 100, 100, 75, 100, 100, 100, they got a good appetite. And then today, they got 25%. As a nurse, what does it tell me? Something's changed. And that means that I need to go find out what that something is. That's all these are used for. Make sense? Okay, so don't get too in the weeds on this. 95%, no. 0, 25, 50, 75, or 100. Those are your only choices here, not 95%. Good? Okay, so that's food percentages. Liquid can also be done as a percentage. Okay, can also be done as a percentage. But when it comes to intake and output, when we're doing this scientifically, we've got to be a little more accurate than just percentage. And that's what this is. In America, we tend to use ounces, not metric. But in healthcare, we use metric, not ounces. That means that you guys have got to know how to convert. Good? 1 ounce is worth 30 mLs. If you are serving your patient a coffee cup of coffee and your patient's on intake and output, you need to know, and they drink that whole cup of coffee, you need to know how many cc's or mLs to put on the intake and output sheet. We don't use ounces. So it could be a 6-ounce cup of coffee, but that's not going to help us because we don't use ounces. We need to know how many cc's or mLs was in that coffee cup that the patient drank. So the way we would do that conversion is 6 ounces, multiply it by 30. Stop. 6 ounces multiplied by 30 is 180. So this patient had 180 cc's. Cc's, mLs, same thing. In healthcare, everything has 2 names. Multiply ounces by 30. Now, if you're using a pre-packaged juice or milk or something like that, it actually tells you on the package. So look at that, Alani, right there. How many ounces at the bottom? 12, yeah. How many mLs? 355. So because it's telling us, remember we said 12, we would multiply by 30. 12 times 30 is 360. What does it say? 355, right? So we would use what was on the can. If we do the calculation, we would get 360, which is close. But if the can tells us 355, we're going to use that instead. So pre-packaged liquids, juices, milk, that type of thing, go with what the package says. If we're using a water glass or a coffee cup, during orientation, they're going to tell you our water cups are 8 ounces. Our coffee cups are 6 ounces. You're going to know, our soup bowls are 6 ounces. You're going to know during orientation how many ounces each one of these things are, and then you would do the conversion. Good? Good. All right. So in your book on page 106, you can do this on your own, but there's a whole activity there. But I want to go here real quick. I know I've got 2 more minutes with you. I want to go down here at the bottom of that second column. If we have 6 ounces of juice, we would multiply 6 by 30. And what does that give us? 180. So that's 180 cc. So put 180 on that line next to 9. Our juice, our milk carton tells us it's 240 mLs. So how many is it? 240, because we always go by the carton. Write that in. And 12 ounces coffee, that is 1 big coffee cup. 12 ounces, if we multiply 12 times 30, we get 360. So you should have 180, 240, and 360 on your 3 lines. But at the end of the shift, we have to add them all together to get our total intake for the shift. So if we added 180, 240, and 360, anybody care to guess? 780. So your total intake for the shift will be 780. You will get a math question on the state exam. You will either have to convert ounces to mLs, or you will have to add up intake. You will have to do one. They don't make you do both. You will do one or the other. Good? Questions on intake and output? Easy peasy?
That could get complicated with solids. Yeah.
Solids don't play into it.
Okay.
So it's liquids. We're going to measure liquids. Solids would be that percentage-based scale. Even on intake and output, yeah, still percentage-based. The only thing that we can measure are liquids. On page 132, you've got a list of medical abbreviations. Everything that is highlighted in gray is something you need to know. We'll be talking about this a little bit more next class, but familiarize yourself with this. There's a whole activity there on page 133 that you can use to kind of get a feel for how these are used. NPO, you need to know. NPO, you need to know. Nothing by mouth. That is correct. It is abbreviated Latin, not English, guys. Don't try to make sense of it in English. Doesn't make sense. It's abbreviated Latin. You had a question.
So I was wondering, wait, hold on. I forgot my question. I'll come back.
Okay. For those of you who came in a little bit late, there is a note on the bathroom mirror. Please make sure you go in and take a look at it. If that applies to you, please, please, please rectify the situation, because Julie, who has been so gracious to let us use this room, is upset. And I don't want her upset. So if you have not had a chance, please go in and read the note on the bathroom mirror. And I will see you guys on Wednesday.
I remember. So when you give us the review sheets, like the first time, didn't you say that everything on those review sheets would be on?
It's going to be a good, yeah, a good
For
review
study
packet.
guide?
Yeah, for the state exam. Yep. You're welcome. I am. Thank you so much for joining us live. We truly appreciate it. We will see you for class 6 on Wednesday. The following week, next week, we have our game show coming up on Tuesday as well, the first Tuesday in November. Hope to see you there. Until next time, happy caregiving. Bye.